Good morning, one and all. I welcome all of you on this day 2 of our PuneCon-22. To begin with our first session of the day, every anesthetist should be aware of the medical legal aspects of anesthesia practice, as it is very important for modern medicine. So to elaborate on the same, we have our first session of the day on medical legal update. I kindly call upon the stage Dr. Pratibha Kane and hand over the proceedings for the first session.
Good morning, everybody. Today we are doing a hybrid session, and it is my pleasure to welcome for this session our chairperson. Uh, next slide नहीं होता है. All right, so we have our chairperson, Dr. Kalpana Kerkar, who is professor and HOD of Department of Critical Care Medicine in D.Y. Patil, Pimpri. She has many major achievements. I'm not going to spend any more time on this, but she, I think, has is a recipient of the best research papers and a recipient of Lifetime Achievement Award for Anesthesiology and a recipient of the Hall of Fame Award for Poetry and Devotional Music, and many publications to her credit. We also have our chairpersons. Next is our Dr. Khon, who has trained in Vijay Medical College. Today she is presently teaching at Noble Hospitals, Pune, and she has 47 years of experience behind her. And she has, was instrumental in those days in organizing workshops for surgeons, and her major projects have been tracheal reconstruction surgeries, and she worked as a chief anesthesiologist for operative workshops of head and neck surgeries. For our speakers who are joining us online, our experts, we have Dr. Sadhna Kulkarni, who is speaking to us from Aurangabad, and she is professor and HOD of emergency medicine and in charge of skill development unit in MJM. She also has a tremendous amount of awards, national and state awards for public awareness about anesthesiology, and Lifetime Achievement Award of PROACT. More than 80 publications to her credit, and her winsome smile is, I think, the best. We have with us Dr. Naurange, who is an accomplished pediatrician, but he is really our go-to person for any medico-legal problems in Pune. He's the Iron Man behind a very active medico-legal cell of IMA in Pune. With this very short introduction, we are going to start our session, and on three very important topics. Basically, not to elaborate too much on the topic, but just to create an awareness that these are problem areas, and one has to deal with them in their area of influence. So, sorry. Oh, I'm so sorry. No, I thought. I'm really sorry, sir. Dr. Meenakshi Sundaram, I can say he needs no introduction, but no, he's got the Best Teacher Award and the Best Doctor Award, and he is a Tamil poet, which is really so amazing. And he has tremendous knowledge and an extreme, Dr. Bhatia is saying, extremely great sense of humor, and yes, I will give him credit for that too. I'm so sorry, Dr. Sundaram. I think I just wanted to get on with the subject. All right, so he is actually leading us on the first topic, and that first topic is pre-anesthesia consultation with a physician. So the question is a physician fitness a legal requirement, and how does it add value to the anesthesiologist? Dr. Sundaram sir, please.
Thank you very much, madam. First of all, I thank the PROACT Pune team for having given this wonderful opportunity to me. Now, first of all, I want to make it clear that I am going to talk as a legal person. Please don't consider me as an anesthesiologist and don't argue with me in medical science. It is totally different. That is, every time I am facing the problem, I am not an anesthesiologist. Please forget about it. Now, this question needs some elaborate answering. Is physician fitness a legal requirement? First, straight answer, it is no. Because the National Consumer Disputes Forum has given that verdict that anesthesiologist is responsible for pre-anesthetic fitness. So, fitness is not a legal requirement. Then, the anesthesiologist, they may argue and they will ask me, as an anesthesiologist, if we are having a problem, what we will do? By coping in so many interdepartmental consultations, I feel personally we have been dragged into a trap. I will quote only one example because I have only 2 minutes time to answer this question. See, the present case, very recent, in the August 2022, Shankar Netralaya case, the case was filed in 2000. After 22 years, the judgment was delivered. You have to read that judgment because it is extensively discussed. A 6-year-old boy undergoing strabismus surgery was dead on the table. So the court has observed about pre-medication of atropine, how atropine acts, what is oculocardiac crisis. The judge says the atropine was not given in proper time. The halothane and the scoline has produces bradycardia and hence there is cardiac arrest. So this much of a discussion is there in the case. But what I want to convey, the patient had a soft systolic murmur as per the physician's opinion. So the physician wanted cardiologist's opinion. The cardiologist auscultated the patient in so many ways and he said no murmur, absolutely no investigation is necessary. So the anesthetist has taken up the case. But in the judgment it has been mentioned, the cardiologist has not examined the case properly. As physician has marked that there is a soft systolic murmur, he should have exerted extra precautions, but the cardiologist have not done that. Fine. So far it is fine. The compensation ordered was 1 crore. Imagine the compensation ordered was 1 crore. In 1 crore, the court has opined 85 lakhs have to be paid by the Shankar Netralaya hospital as vicarious liability, and 10 lakhs by the anesthesiologist and 5 lakhs by the surgeon. Now where is the cardiologist? The court, see, this is what happens. The court says the cardiologist could not be implicated in the case just because he was not mentioned as a respondent. The patient team knows only the anesthesiologist and the surgeon. So if you are getting interdepartmental opinion, he may not be implicated in the case and it will invite a problem. Another example I will tell you, if there is a T-wave inversion in anterior chest leads, it may be normal below 40 years if it is a female. But even if it is there, if you ask for an opinion, then they will say, they will not go to the ECG finding. They will say it is fit for anesthesia. There only the problem comes. So, don't ask for unnecessary opinion, one, right? If you don't know about the diagnosis, you consult the specialist and inform him he is being consulted only for the diagnosis, not for the fitness. If T-wave is inverted, he has to commit whether it is a coronary or not. That's where we have to stand. So it is not a legal requirement. And is it valuable to anesthesiologist? Absolutely no legally. Absolutely no legally. That is my straight question. Then if you want to have more opinion, you please discuss with him personally. But it should not be written in the case sheet that he is fit for anesthesia Sometimes they are writing is fit for general anesthesia, he's fit for spinal anesthesia. These are the things should not be written. It is not a foolproof technique for the anesthesiologist. Thank you.
Dr. Kerkar wants to say something.
Hello? Hello?
Yes, madam.
So thank you very much for enlightening us that it is not a legal requirement. It is such a big solace because physician's fitness actually even in my tenure I always can't hear. Hello? Dr. Sundaram, can you hear me?
Yes, yes, I am listening, madam.
So I will start again. Thank you very much for enlightening us with this fact that it is not a legal requirement. Because so many times it so happens that actually I feel that anesthesiologist should be the perioperative physician giving fitness for anesthesia. And this word of fitness should actually be outdated. I mean, it should not be used anymore. We can just do risk stratification. And I always used to tell my students also that refer to physician only for proper diagnosis and optimization of the patient, which can be done medically. Otherwise, whatever perioperative medicine we know, we are definitely superior to the physician in giving the advice about this. And I was under the impression that it is a legal
I
requirement.
don't want to say we are superior, we are better. Because it is a legal question. I want to say we are better.
Okay. Thanks for correction, we are better. But then that is a big solace, I think. Thank you, sir.
Okay, I beg to differ slightly on this. To me, I feel it is in today's day, it is a little dangerous to be perioperative physicians because we have very limited time to look at patients. And I feel that this is the time to spread responsibility because after the case is over, we have to hand over to some physician. And especially if they have comorbidities and on medications, and we have seen just now, actually I have not put up those cases, but cases going into court because they have not been BP of 140/90 and they say that patient has not been treated by a physician. So what I want to round up and summarize this by saying is that there is no harm in getting, in fact, I feel that, we should get physician involved, but the way we refer is not for fitness. The way we refer is, like Madam said, for optimization and the fact that there are perioperative risks. So if the medical person actually states that this person who has had a myocardial infarction before is having some risk of having a myocardial infarction in the perioperative period, a person who is asthmatic may have an asthmatic attack in the perioperative period or may need ICU, it really supports the anesthesiologist.
Here
I agree with Dr. Pratibha because the post-operative care, if we involve the physicians, the care is definitely better because surgeons are alone, they cannot manage the medical conditions.
Here the most important thing is when we refer to the physician, even if you say that he has to counsel the patient's relatives, actually the catch is, suppose a diabetic patient is taken for surgery, sudden cardiac death syndrome is a known entity in diabetes. If post-operatively something happens to the patient and the physician has given fitness on paper, the court can say if the patient was fit, why this complication?
That is why do not refer for fitness. Refer for just take that fitness word because anybody who is coming for a surgery cannot be fit to run a marathon.
Madam,
a fit person.
And basically, no patient is fit or
Madam.
unfit.
Yeah.
Madam, that's what I said. You refer the case for a diagnosis. But see, the problem is they are writing. Madam, they are writing. Then what you will do if it is written in the case?
So that's what I'm
That
saying.
is the reason why beforehand.
Change the physician.
Beforehand.
No, we need to
Create awareness.
Inform.
create
Beforehand,
awareness.
inform
Why
the
I
consultant.
have brought this topic up is to create awareness that please do not refer for fitness, whoever physicians you are involved with, ask them to write a detailed thing, at least mention the comorbidities involved, and they must counsel the patient, even mentioning about few perioperative risks that the diabetes may get worse or something. They must talk of some risk.
That is not possible, madam. Their training is entirely different. I beg to differ. Their training is entirely different physician. Even I want to say, even in the post-operative period, I feel 24 hours it is our moral responsibility to take care of the patient. Because the surgical causes of bradycardia, surgical causes of hypotension, that may not be examined by the physician because their training is like that. We are trying to do that. So it is not perioperative physician or not. Please understand, we have to take part in the post-operative care also because our brain helps the patient. I am talking about the patient, now not about the legal requirement. Please, it is not just handing over once the moment anesthesia is over, then it will be like nurse anesthetist. We are anesthesiologists, we are saying. So I feel our knowledge is to be utilized. See, we are all learned people. We know how judiciously it could be operated. I am not overstepping, same way I should not understep. That is my request.
Okay, so I leave this open. As far as I'm concerned, I like to hand over because it is really very difficult for everybody to keep following up, and anybody who is in any kind of risk about bradycardia, hypoglycemia should go to the ICU. I mean, we are at least in institutions we tend to do that. That anybody who we feel is in risk of any kind of thing, but we do hand over to the physician. We do not continue to give care. Okay, so this is our kind of what we follow over here. We do not. We really hand over a patient who has come properly out of anesthesia over to the physician to take over their insulin requirements, their cardiac drugs, and everything else.
Madam, only one word, madam. We are not talking about your setup or my setup. Now it is a legal forum. That is the reason clearly I said.
Yeah, so
legally,
legal responsibility.
even if you hand it over to the physician, legally you are responsible.
Yes.
Legally, I am talking about legally. Don't talk about scientific matters. Legally, we are responsible. That's the carry home message I want to convey. Whether you hand it over to anybody, legally you are responsible.
Thank you.
Okay.
Nange wants to add something.
Yes, sir.
Yeah, madam, I listened to all these discussions, and these are age-old discussions. But what sir was referring to is a very unfortunate judgment, I would say, that a cardiologist is let alone. But otherwise, I would say that maximum number of opinions play the defensive medicine. The cardiologist should have gone for investigations if somebody has suspected some murmur and all that. And I think it must be the story of 2000. That is why they did not do any investigations. Otherwise, nobody tends to auscultate to that extent, but go on with the 2D echo and all those. But anyway, sir, ultimately what I feel, there is one very good judgment. I don't remember the Supreme Court judgment's title. It says that you can, I think it is in this Armory case only, that you can involve maximum number of consultants, but there has to be a captain of the ship. So ultimate final decision rests on one person who is taking the lead. So really the decision, I mean ultimately the responsibility will be on the anesthetist who is giving the anesthesia, but then involve as many number of doctors as possible and play the defensive medicine is the role today, which is not our teaching really, but then law has taught us now.
Alright, so we are going to go on. So we leave this debate as is. As far as possible, I would say involve more people and hand over responsibility. But okay, there is a difference of opinion. Now we are going to the next topic, and the next topic is off-label use of drugs. And Dr. Sadhna Kulkarni is going to kind of lead us with her knowledge and experience.
Thank you, Dr. Pratibha, for giving opportunity to talk on this grey area. And really, when I was preparing for this lecture, I learned many things. First of all, I want to clearly state that off-label use is not legally accepted in India. Now, when the drug comes in the market, it comes with the label and in which the various conditions are included where the drug can be used regarding the age, indication, contraindication, and dosage form, etc. But unfortunately, 20% of the perioperative anesthetic drugs are off-label. And in this condition, why anesthesiologist is forced to use that? Because he is facing different types of conditions, different types of severity of the diseases, and he has to use the combination of the drugs to maintain the cardiovascular stability or to prolong the analgesia. So that's why off-label use is common. Now, then are we exposed to more medical legal liability in such conditions? Yes, because the policy is variable all over the world, and FDA, it permits the use of off-label use for prescription if it has come into peer-reviewed journals and it is scientifically proved. So also it allows the companies to promote that off-label use if it is based on the two peer-reviewed journals. And while in India, the thing is, if the DCGI doesn't give clear-cut guidelines, legally we are not allowed to prescribe any off-label drug. And second is, in India, the government says that you cannot apply FDA rules in India or guidelines because our people are not that educated, and because of that, and our prescription in India is affected by the pharmacy. So that's why we cannot apply those guidelines in India, and we are not allowed to use off-label drug uses. Now, in such conditions, what the anesthesiologist should do? When we are using, we must see that if it is a off-label use, is it given in the textbooks? So if it is given in the textbooks, legally that drug will be accepted. Second is document everything on the case paper, follow the patient and tell the patient that we do not know the side effects of this particular drug, so that the legal aspects can be minimized. And if you find any adverse drug, please publish it and also tell to your colleagues that these are the off-label use, so that the others won't use that particular drug. So, and for the institutes, I want to tell that if you are participating in phase 2 trials, please see that the DCGI approval is there. So also animal and human study report is there, and then only you try for that DCGI trial, and the insurance of the patient should be there when we are doing the phase 2 trials. So these are some of the precautions which we must take. Now, can we streamline this problem? So for this, what we can do is government, pharmacy companies, insurance companies and the doctors, they can come together and discuss this problem. In 2004, I think IMA has represented to government for allowing FDA guidelines in India, and the decision was not taken, and yet it is pending. So it's more than 18 years, and definitely the people have now changed, because the COVID-19 has taught off-label drug use to everybody, and we have seen what are the side effects of those drugs. So unless we come together and create awareness, I think this problem cannot be solved.
Okay, ma'am. Dr. Kohn would just like to.
Hello. Hello, ma'am. Thank you so much for enlightening us on these aspects. Not aware of the legal implications of the off-label use. She said the Director Control General of India is only one, but unfortunately cannot lay down practice exactly like FDA. But in India, it has been banned and illegally banned, not to use, market, manufacture, everything about the off-label use. And you are liable to be punished in case the court or the receiving body confirms that the parent drug, whatever, has been tested and approved by FDA. Secondly, it was indicated for the requirements of the patient's off-label indication, and there have been enough trials. That is what is exactly what is required in the current scenario. As ma'am is rightly put, there is a lot of ambiguity in and confusion and no clear-cut guidelines for this. I would like to make a mention of the efforts put in by IME, national body, in liberalizing the use. Because the major concern to the trials, FDA believes in trials. No, we don't have the trials in pediatric age group. So are we depriving the children? Because just because there are not enough of trials. And unfortunately, ma'am said, the percentage probably is much higher than ma'am was said, that many percentage of the drugs are still being used off-label for the benefit of mankind, especially the pediatric age groups. Ma'am, if you allow me to share, take extra minute, I would like to share my views and pay my respects to my dear friend Ketmin. Ketmin, when is introduced, we have been using off-label applications of ketamine. In 71, when Thomas gave us ketamine for only IM and IV use for induction of anesthesia, over a period of time, slowly we started using it as a sub-anesthetic dose, 0.2, 0.3 per kg, okay, and then outside OT for sedation. I am grateful that I have saved many children for intractable touch spells when everything failed, beta blockers. Desperate scenarios, amazing for the cardiac release, but what have we done? Kidney and intractable. How can I forget intractable status asthmatic in age group? The last indication, all the, including phosphodiesterase inhibitors, were not at all working. Now, we are coming across the mood depressing and mood elevators and mood changing applications of ketamine, and FDA had to approve esketamine, and the R and I. The esketamine, which is intranasal, has been finally approved of late by FDA. So, there is another side of this coin which we have to accept, and if it is being done in the best interest of the patient. Please remember that off-label use, if it is proved, is liable and punishable. A law does not permit in India, and there has been amendment. But make sure that it is not causing any harm to the patient. Make sure that you are within the legal frameworks and I think we can find so many examples of off-label applications of being. Thank you so much. Thank you so much, ma'am.
Dr. Sundaram, would you just like to add a comment?
Again, as a legal person, we will say no.
Exactly. That's
Because the Sadhana madam and chairperson madam has clearly explained. But it is very clear, when it is off-label, legally it should not be used. Then our people will argue, it will give post-operative pain relief, it will give nice sedation, no scientific arguments. It is not allowed. These are all the things we have to be very clear and careful. Off-label drug usage is not allowed legally. And once you say off-label, immediately the court will give the verdict. It will not even ask for expert opinion. Immediately it will be done.
Dr. Naurangi sir, would you like to comment on
Yeah, I think I totally agree with the discussions going on, but I would draw attention to one particular judgment which is quite celebrated judgment from Kerala High Court initially and then Supreme Court, in which the off-label use of sildenafil for pulmonary hypertension was initially allowed, and that was an absolutely off-label experimental drug. So, though it does not follow this, I mean, generally whatever has been mentioned is correct, but once in a while, such a life-threatening situation can be allowed by the courts. So, it depends on whether it is that critical.
Sir, and proper documentation, I think, is the key. That all other, treatment has failed or things like that, and how or why you are using that drug.
Madam, again,
I would like
as
to
a
ask
defender,
something.
Madam,
Yes.
as a defender, in case if we have used, we can say, as Sarah has mentioned, if it is a pulmonary hypertension, we can defend ourselves that when the Damocles sword is hanging over
Yes,
our head,
yes,
we
yes.
have to select a way. But it is not applicable for this post-operative pain relief and all.
No, no.
Mostly we are using off-label drugs only in the central neuroaxis blockade. Only in the central neuroaxis blockade, or this dexmedetomidine or sodium bicarbonate in the regional nerve blocks. So nowhere our usage of additives, mainly we are using only additives. It will not come in life-saving measures. But
That's right.
something has happened, you try to defend.
Yeah.
That you have selected a choice between devil and the deep sleep, which
And
is
even-
again to console the people.
Even in the life-saving
Unfortunately,
situations,
ninth
should
edition
we
of
be
Miller,
taking
all
a
these
consent?
additives they are mentioned.
Ah,
So this is the safety for us. And as Dr. Naurange said, that it is only for the rare or the orphan diseases
Yes,
that
yes.
off-label drugs use.
Can be tried. It
No,
be
but
tried.
for example, I am just asking, as Dr. Sundaram said, that post-operative pain relief is not an emergency situation. Suppose an anesthesiologist has got an experience that such and such addition is useful. Can we take an informed consent from the patient that this drug has been used by us and it is not accepted by FDA? Is it allowed or it is not?
Dr. Naurange sir,
No, I think it is not allowed in our country.
not enough.
Madam,
And unless you have clinical trials, I mean, you have to then put up a clinical trial. So, all right. So we're going to close this topic right here. And next,
Madam, wait.
you will. Okay, tell me.
Sadhana Kulkarni, madam, can you explain, can we use certain drugs, pharma company advice for the suppose for intravenous use? The same drug, can we use intranasally or other routes or intrathecally or separate
It is mentioned in the label, then only, otherwise not.
No.
Okay.
So, the one small thing I would like to ask is that before we used to, for theses, for students, we used to keep on giving things, and then suddenly after I did some research on this, I realized that we cannot just give it for any kind of a thesis because we don't have the background of clinical trial. So it has to come like a clinical trial if you're trying something new.
Leave aside changing the route. Even if we are using an age-old drug which has been used systematically, I have given the topic in a dissertation when steroids were being used as antiemetics, and the expert asked me, "Okay, have you taken DCJ approval?"
Yes. So please be careful. This is just to increase your awareness. There are so many teachers here and everything. So just thought I would, kind of just bring this up right now. All right, we'll. One question. Okay, do we have time? I mean, we have one more full thing to answer, to go.
Just one question to Sundaram sir.
Sundaram sir, yeah.
Sir, you are saying that we need to follow up the patient post-operatively. Do we have any specific duration? Will it be 24 hours, 48 hours,
Yeah,
or
that's what.
same that
Sir,
peri-operative
I will
anesthesia?
tell this, sir. This is a very grey area. See, it is not the hours, sir. It is, if it is related to anesthesia, then it continues. Like if suppose some complication has occurred during the perioperative period, it will continue. So it is not the time. What I said, whether legally or not, morally we have to take care of the patient because we know what is happening and we know what drug we have given. Because some people will give atropine and ephedrine in the perioperative period. Post-operative period there will be a high BP. If the physician is seeing that, he may not interpret that because his training is different. We know what we have done. That is the reason I am saying it is a moral responsibility. Legally also we are responsible whether we hand it over or not.
I
All
think
right.
let us go ahead because, madam, please, questions will be discussed later on.
Yeah, because we are short of time. This is really to just increase our awareness. All right, so we are going on to Dr. Naurange is going to lead us into a very important topic, which is MRI and patient safety, and what are the lessons for the anesthesiologist, because he has just recently handled a few cases in Pune with very poor outcome. Naurange sir, please.
Yeah. So can I have the first slide, please?
Yeah.
So thank you very much at the outset, all the organizers, Dr. Professor Kalpana Kelkar Madam, Kuhn Madam, and Pratibha, and also very nice to listen to Mr. Dr. Sundaram and Dr. Kulkarni. I think increasingly anesthetist is required to give sedation or even short anesthesia relaxation for very many procedures in diagnostic centers which may not be attached to or stand-alone diagnostic centers away from the hospitals. But then there are many situations, in particular neurosurgery, where they are required in the OTs also. And the problems are really inherent. The procedures need sedation, anesthesia, short or long duration anesthesia, muscle relaxants, regional anesthesia, and sometimes in the odd positions of the patients. There is nothing like short, small dose or minor procedure. That I always hate these words, short procedure, minor procedure. It is the maximum accidents which occur in the minor that you are not prepared. So there is nothing like those things. MRI utilizes the anesthesia services maximally, but sometimes you require in CT, ultrasonography also. And basically we have to understand that many situations in an emergency, MRIs are required for basically very sick patients. So these are all inherent risks in this. Another problem in our country is that MR compatible machinery, ventilation, monitoring equipment, resuscitative equipment is so prohibitively expensive. And I don't think this is rather available even in the major cities at many centers in a city like Pune, Bombay, etc. So practically non-existent. And inherent, so you have to take out the patient in case there is a mishap. And inherent problem is another thing is long acquisition time. The patient has to wait for a longer time. Then for you it is an unfamiliar situation and a peculiar environment. I think the basic legal principle on this, that as an anesthesiologist we cannot absolve ourselves from saying that these things were not made available to me. I was new to this particular situation because of this very important principle that has been laid down long before by National Commission and of course by Supreme Court in Rashmi Fadnavis and Mumbai Grahak Panchayat case, and also in Martin D'Souza, that though he might not, that anesthesiologist might not have been directly engaged by the patient, usually they are called by the center or by the another consultant. The anesthetist is a separate legal entity, that he is a separate independent consultant, and therefore the liability is completely of his. You cannot absolve that the patient did not involve me directly, so there is no privity of contract between the two. So that is the underlying principle. So a lot of responsibility lies on the person administering anesthesia. Can I have the next one, please? So the precautions remain the same. So initially check why this. So these are the things which are mentioned in various books. I won't mention about the references. Why this procedure is required, what is the procedure, who is doing it, where it is being done, how it will be done, and when, the timing of it. So we have to ensure the trained staff monitoring, familiarize yourself with the situation, locate the nearest resuscitative facility, whether there is a crash trolley which is prepared, oxygen, defib. So these are the basic things. So preparedness for the life-threatening situation. American Society says that in addition to all which I already outlined, emphasis on pre-operative assessment and investigations, informed consent, intraoperative care and post-operative analgesia remain the same. Choose the diagnostic center after verifying its. What is happening is that most of the seasoned or senior anesthesiologists, they say no to go to diagnostic centers. And it is a young population who are in need of the practice. They fall prey to these situations and they don't have the daring to say that I will not do these things over here unless you provide me these things. So I will come out with a solution also. So choose the diagnostic center. It's easier for me to say than practicing after verifying its authenticity. So we are not going to say that whether it has been licensed by corporation or not. But basically, theoretically, we have to see that whether the person is having the moral integrity, as what sir was saying. Check all the facilities of monitoring and ventilatory equipment, basic at least. Check the consent yourself. Don't leave it to the nurse and assistant. In case of emergency, we have to see that basically the informed consent is there and also the basic facilities are there for ventilation. Can I have the next one, please? then point out, in case you find out the deficiencies, we have to point out the important deficiency, lacuna or upgradation, and request them for the subsequent procedures at least. If after a reasonable period of one request, the things are not improved, you have to request in writing. This I am telling you from various judgments, that you are working in a government setup, you are working in a corporate setup, or you are just working in a very totally individual private practice, but the things are not improving. We have to write a letter. We have to take the acknowledgement of that letter that he has received it. Once that is there, something happens, you are fairly, I am not saying completely, but fairly protected from your side. Have luxurious, that is 1 to 2 crores minimum professional indemnity insurance. And this is required for every anesthetist, everybody. I am not saying those who are going to the diagnostic center, it is required, because minimally I had detailed discussions with 2 judges in the Bombay High Court. They said that 1 and 2 crores is nothing these days when it is a life liability. So the compensations are bound to be like that only. And also request the diagnostic center to have their own indemnity and establishment insurance. Always, of course, that is, taking insurance is not a license to create or commit negligence. I am not saying that way, but that is a tertiary prevention. Always take a few minutes to talk to the patient or relatives and involve the physician who has asked for this particular investigation. So that is very important to do it before procedure, not to involve him in a life-threatening situation when the patient has become comatose or has become a brain death patient. As usual, categorize the patients into age, risk, and optimize him. Then I have the next and probably the last slide. Never leave a critical patient unless you hand over to a competent caregiver. Supposing you are shifting, it is our responsibility to hand over to the responsible person. Do not make any hurry to leave the patient unless he is maintaining his vitals well, either with his own or with the assistant. I think this is partly the answer. Somebody asked how long the anesthetist should be there after the procedure. If table death has occurred, follow the usual procedures what you follow in a table death. Involve the medical legal friend immediately in case of any crisis. So don't hand over the papers unless you have involved medical legal friend. And my request to the anesthesia, so this is a long-term solution, that they should formulate minimum locally practicable. What happens, madam, is that many times we just borrow, or the government borrows the guidelines from Western countries, where I am right now. They cannot be just followed in each and every nook and corner of our city and our country. So there should be locally practicable facilities at diagnostic centers and methodology of assessment, consent, staffing, equipment, etc., and bring uniformity and keep the individual, that means individual anesthesiologist, from any personal embarrassment by asking that these are the things which are required. Once the association puts down the basic guidelines, it becomes easier for him to insist on these. This will surely help in the litigations. I think the next slide is just many cases, so we need not go into them for want of time.
Okay, sir, I'm just going to ask you this usual question. Somebody calls you from the MRI suite and they say patient is not able to lie down and thoda sa yaun sedation there.
Yeah. So for that also these basic principles will remain, that see that basic equipment is available and at least one trained assistant is there and a proper consent is taken.
And I personally feel
the risk of depression remains, the central depression remains the same.
I personally feel that it is better to take this person out, do a proper check, and then put it, because they are usually not emergencies, they are usually back pain, they can't sleep. Yes. And it is always better for the anesthesiologist to not just go anywhere, look for a vein and just start sedation. You don't know what the patient did. He may be asthmatic, he may be anything. It is better.
Legally only one point in sir's statement. Number 11. Point number 11. Sir, please correction. Prepare the notes. It has been written as prepare the notes. Calling the police, expiry. It is not prepare the notes. It is writing down the notes. It is legally, as we are talking about legally.
No, I would explain. Sir, I would explain here. You have always the legal prerogative to ask for time, because on the spot the police come and they try to grab all the records. So they will buy the time. That is what I am saying. Prepare the notes means
Prepare is
before
a
handing over to the police.
All right.
Proper notes. Preparing the proper notes before handing over.
Okay, I know this is becoming slightly long, and I thank all the speakers for doing such a great job. This whole session was about increasing awareness about these problems, not really solving the age-old problems, but I think in your own area of authority, you can slowly start making the change, and I think then we have served our purpose.
I would just like to add one thing because I'm sure that many people might be having many questions. We don't have time. So if you can hand over your questions to us, we can get in touch with all the
Okay,
authorities
these
which
are
there.
telephone numbers. Sorry, you can just take a picture and you can, kind of contact these people on your own. All right, changing the slide. Okay. Yes, madam.
Can I just have a few words about
Yeah.
this previous one? Just one line
Yeah.
before we begin. Okay. Regarding the MR, I would like to share the legalities involved and the basic morbidities and mortalities related. The patient, the relatives, and the team member, basically related to the hypoxic deaths, apart from the flying object injuries attracted to the magnet. The quenching of the magnet is one thing, and why the patient died because of most of the cases which have been reported are hypoxic because of the cooling agent, that ozone and helium, which liquefies and gases and displaces the entire oxygen. So we have to be responsible. We are responsible in maintaining the environment and maintaining it. So that's the most important thing, which has found the legal implication and thank you.
All right, so we're going to go on to our next speaker, Advocate Rohit Erande, is so used to saying doctor. Okay, so now we are just finding his CV somewhere, but I think he can take the dais. He is very much involved with lots of blogs, and he does a lot of awareness work for doctors and I think for lawyers also. Yes. Okay. So let me call Dr. Rohit Erande. We've lost his CV somewhere. Oh, he did. Oh, he's there. All right. So let me just read this. He is LLB, LLM, and he is a member of the Bar Council of Maharashtra and Goa, and greatly accomplished. He has done, see, those 350 medico-legal blogs, okay? So, and he is quite gifted. He has, kind of written some book which was published, and he's invited as a speaker. And once you hear him, you will understand what he is trying to say. So we are now, you must be seeing in the papers that FIRs are being dropped on doctors left, right and center. And let's hope he is going to just make us a little bit less worried. Thank you.
Good morning, everyone. Thank you, organizers, for giving me an opportunity to share my views. Perhaps I have attended many conferences, but this is the first one for the anesthetists who are regarded as unsung heroes, or I may say they do the thankless job, because the patients are not aware who their anesthetist is, and rather anesthetists are involved also. Many patients are not aware. Just a minute.
Sir, are you all able to hear? Okay, so yeah, they want to be.
I know. Yes. So as I was referring to that I would say that I'm before the unsung heroes of any operation or any procedure. Now, see, you may be the unsung hero or you may be doing the thankless job, but when it comes to any legal complications, you are treated as at par. So now, as whatever I'm going to share my views, I already shared my blog with Dr. Kane madam, so you may please circulate with your colleagues. Now, as you all are reading in newspapers in nowadays that FIRs are being lodged and there is a tremendous increase in filing of cases against the doctors in medical legal cases, medical negligence cases, and the patient has twofold rights: civil litigation, civil case, as well as the criminal litigation. Now, the civil litigation is filed for claiming damages, and criminal litigation generally comes when if there is any death of a patient, then the police machinery is involved, and then automatically the case is filed. So now I will be stressing more on the criminal aspect because see, nobody wishes to go behind the bars, and we try hard to save ourselves from going into the police machinery and going behind the bars. Now, in case of any death, because see, generally FIRs are lodged when there is a death of a patient, if not in other cases of medical negligence. So the first section which is applied by the police, I am pausing here for a moment. Please always have in mind that it is the prerogative of the police authorities to frame the charge which they want. So which section is to be applied? It is the first prerogative of the police. They may apply any section under the IPC. It is their right. Whether that application of section is correct or not, that will be decided further by the court. So if there is a death of a patient, then most of the doctors are feared about section 304. That generally we all are aware that culpable homicide not amounting to murder. So this section is divided into two parts. Culpable homicide amounting to murder, म्हणजे आपण ज्याला मराठीत खून केला असं म्हणतो, and culpable homicide not amounting to murder means the person knows that the person is going to die, but he had no intention of killing him. So in medical legal cases generally fall in part 2, and this section is I would say very important because it is a non-bailable section. It carries 10 years imprisonment as well as fine, and this is a cognizable offence. So FIR is immediately lodged. And the subsequent section is 304A, part 304A, causing death by rash and negligent act. So that is a bailable offence, and the punishment is only of 2 years. But now if suppose a patient is dead in OT and the police machinery gets involved, then which section is to be applied? It lot depends upon what police is going to play the role. So see, there are many ways, there are many I would say facets of it, and right now I cannot tell how to deal with the police and see, because ultimately you are answerable to police. Now going back to the 304 part 2 matter. Now previously what used to happen is that एखादा पेशंट गेला की पोलीस यायचे आणि डॉक्टरला लिटरली दे यूज टू अरेस्ट, डॉक्टरला उचलायचे, आपण जो मराठीत शब्द वापरतो. सो म्हणजे दिस इज अ मोर डेरोगेटरी वर्ड, बट फॉर देम की आम्ही डॉक्टरला उचलला मीन्स टू मेक द अरेस्ट ऑफ द डॉक्टर. बट आय वुड से दॅट इन द इयर 2014 Honorable Apex Court in its 5 judges constitutional bench judgment gave a very important verdict that in case of a death they have made the 5 categories that and the categories are matrimonial dispute, commercial offences, corruption cases, abnormal delay in filing FIR, and the last one is medical negligence cases. So they have specifically added medical legal cases, medical negligence cases, and what they have held that it will be unfair and inequitable to prosecute a medical professional only on the basis of allegations in the complaint, and this is what used to happen previously. So after this judgment, now a preliminary inquiry is a must, And unless that inquiry is done by the police authorities, that is, unless they obtain a report from, in case of Pune, say from Sasun Hospital of expert committee, they cannot, arrest the doctors merely because the patient is dead. So this particular, I would say, the important factor was not previously available, because we all are aware of the Jacob Matthews judgment. Which they have defined what should be the negligence, what the negligence should be the gross, and then only a doctor can be criminally prosecuted. But this authority was applicable only 304A, where the punishment is only for 2 years. But if the police used to apply 30 part 2, where the punishment is of 10 years, then there was no protection, and the doctor had only right directly approach the Honorable High Court for quashing the FIR. But after 2014 judgment, see, you must be aware of the judgment, because suppose unfortunately something happens and police authorities come to you, then see, you are, this is your right. Right of fair trial is a fundamental right of every citizen, and therefore I would request that you should know the judgment, you should know your rights, and at that time you can always tell to the police that you cannot arrest me in a routine manner, because this is the judgment of Honorable Apex Court. So 304 part 2 and 304A. So which section is to be applied? It is the prerogative of police. Now, another important aspect which I am going to touch here is removal of wrong charge. As initially I just mentioned, charge means the which section is to be applied. So suppose police applies 304 part 2, that you have committed a murder, but not so culpable homicide not amounting to murder, and you are sure that you did your best, the patient died on OT because due to some medical complication which are beyond your control, you can always apply to the concerned court for removal of charge, alteration of charge, or your discharge from the charge. But that will only happen only after the case is registered, not prior to that. So it lot again and again I am emphasizing that it lot depends upon the police authorities, police machinery, because we all are concerned with the currently of the criminal action. Then again another important aspect which a doctor or any doctor or anesthetist should be aware, that you may be called as an expert witness or a witness in any medical legal cases. So suppose you receive any warrant or any summons from the court, or any notice for that matter from the court or from any lawyer, my first advice would be you should accept that. Many a times it is a human tendency, not in any legal cases, की आपण notice refuse करून टाकायची, not claimed करायची, but that is not going to help you, because you won't be able to know what exactly written is there, what are the allegations made against you. Merely because you just say I don't want, you say no, not claimed or unclaimed, that is, you will be in more trouble if you don't accept it. So you always accept that whatever the summons, notice, it is received, is sent to you, but first of all see whether it is in your name, because many a times it may happen in court proceeding, the name is wrong, दूसरा डॉक्टरचा आले, in that case you are right to refuse, because I am not that person. Since you know that it is addressed to you, but you can in that case take the benefit of the technicality. So now if a warrant is issued, if a witness summons is issued to you, you have to obey it. You cannot say that I am not going to. Even if you have written anything on the paper that this paper is not going to be used as evidence in court, etc., etc., असं काही होत नाही. Whether any particular document is admissible in evidence or not, it is decided by the courts and not by anyone else. So you always have to obey the witness summons if it is issued to you. Only thing is that generally the courts do give preference to the witness doctors when they come to the court, and by keeping aside other work, the doctors are given preference in these days, because right from 1987 Paramananda Katraj judgment, Supreme Court has held that doctors should be given priority whenever they come as a witness. It might be the case of attesting to the will, or it might be the case of the medical legal cases. Another important aspect is that, see, as we all have seen now that litigation is going on, many a times cases are being filed against the doctors, and anesthetists are also involved. Many a times it happens that the cases are decided on merit, decided in favor of doctors. Then many of my doctor clients ask, sir, abhi आगे क्या करना है? What's to be done? Whenever I advise them, you have a right to file a suit for damages for malicious prosecution. I have seen in my last 20 years, not a single doctor is ready to go against the patient. See, merely venting your emotions on social media or on WhatsApp, ki this is going, this is not done, this is bad, or where is the society is going, it's not going to help. If you want to set an example, if you want to have some deterrence in the society, then you should initiate, at least some of you should initiate at least a notice. I am not saying that you should go and filing and claim 50 lakhs and 1 crore rupees as compensation, that is up to you. But unless you do, unless one of you do, unless your association do it, see, it won't go a message in the society that you can do anything. Because what is happening is, now this has aspect of civil litigation, CPA. Now the CPA, as it is called as sword of Damocles hanging over the heads of doctors. See, by merely paying 500 rupees, 5 or 1000 rupees, I can file a suit up to 50 lakhs rupees in Pune district forum. Previously, it used to happen for the, as per new CPA, they increased the pecuniary jurisdiction to 1 crore rupees. Now, recently, I fought a case for doctors. It's a very famous case in Pune where 90 lakhs rupees were claimed against a gynecologist for D&E procedure and a patient collapse. And the anesthetist was also involved in that case. Fortunately for us, the anesthetist was not made a party. I don't know who advised them, but all the allegations were against the anesthetist that it was the overdose of anesthesia, and the patient was saying that मी जेव्हा प्रेग्नंट होते तेव्हा मला अनेस्थेशिया दिला होता, मला काहीच झालं नाही, पण ह्या अनेस्थेशियामध्ये मला माझी बायको गेली, म्हणजे त्यामुळे अनेस्थेशियाची मला ॲलर्जी आली आणि माझ्यापासून लपवून ठेवलं. Now there are different types of anesthesias and etc. See, all these things should be made aware to the patient. And what Dr. Naurange sir rightly said, you should have a dialogue with the patient. See, ultimately all the disputes, all the differences start with the ego classes. That doctor bollas nahi main, he had no time, he sent his junior. This won't help you. You have to spare 5. You may examine 2 or 3 patients less, but whatever the patients you are going to examine, at least give proper time to them. And because these 2 minutes are going to save you, because you might be hearing that nowadays courts have awarded few crores of rupees as compensation. And see, ultimately, if you don't have the indemnity policy, you have to pay from your own pockets. If you want to challenge that order, now as per new amendment, you have to first deposit 50% of the amount compensation which is allowed. So in our case, if that the court would have allowed complaint of 90 lakhs rupees, my client would have required to pay 45 lakhs rupees first, then only we would have got the stay. Fortunately, it was decided in our favor. We had a very good case, but it cannot happen every time. And another last point, I am just concluding, documentation has no alternative. Communication of documentation of communication, both are very important. So documentation has no alternative. I have personally seen in one of my close relatives' surgery, the sister took the anesthetic consent. I was knowing all the doctors, the surgeon. I told him, boss, look, what kind of consent is being taken. You are aware that if something goes wrong, I am not going to file a case against you. But if this is happening with reality with other patients, then later on do not complain that informed consent was taken. The word informed is important. So have time, spare time with the patient, and proper documentation again. And because no documentation is no proof, poor documentation is poor proof. Ultimately in courts, the papers speak and not what your moral or your emotions have no value in the court. So thank you very much for calling me here, and I hope if you have any questions you may ask. And I have shared my blog with madam, so you can just go through it because it's a big blog.
Sir, one question please.
Yes sir. Sorry, I am not able to see you because of the light.
Sir, one question. Anyone can claim any amount, like is there any कुठलाही पेशंट
कुठलीही अमाऊंट क्लेम करू शकतो का अंडर CPS सिव्हिल लॉ? असं काही आहे का की सपोज सम पेशंट 1 करोड अमाऊंट क्लेम केली लॉसूटसाठी, तर ही ऑर शी हॅज टू डिपॉझिट सम 20 लाख रुपीज or 50 लाख रुपीज समथिंग लाईक दॅट बिफोर क्लेमिंग?
दिस इज
असं काही आहे का?
असं काही नाही आहे. बेसिकली कोर्टात जाण्यापासून तुम्ही कोणाला रोखू शकत नाही. मला जायचं असेल उद्या तुमच्या विरुद्ध कोर्टात, तर आय हॅव दॅट राईट, आणि मी किती पैसे क्लेम करायचे तो सुद्धा माझा राईट आहे. हे जर सिव्हिल कोर्टात असेल तर आय एम रिक्वायर्ड टू पे द कोर्ट फी, दॅट इज अप टू मॅक्झिमम अप टू 3 lakhs of rupees. But as CPA is regarded as a social legislation, so they have not applied the principle of court fees. So that is where the undue advantage of the CPA is being taken by the patient.
So theoretically anybody can claim any amount?
Any amount. See, now that is depending upon the pecuniary jurisdiction. Now, previously only it was 10 lakhs rupees. Now after 2019 new CPA, they made it, I am talking about district forum, they made it to 1 crore rupees. But again, last say 6 or 8 months back, they again reduced the pecuniary jurisdiction to 50 lakhs of rupees. So up to 50 lakhs of rupees, any claim can be filed in Pune district. Above that, to state forum, and above 2 crores directly to national.
Advocate sir, this is Dr. Meenakshi Sundaram from Tamil Nadu. I am asking by
Dr. Sundaram is here.
Yeah. Sorry, sir. I didn't.
I am asking with Zoom platform, as you have rightly pointed out, it is the prerogative of the policeman to book the section. Same way, what I am asking, we have so many judgments, doctor should not be arrested, everything is there, we are having it in hand. But again, the police people are arresting, knowing or without knowing, we cannot discuss it in the open forum. They are arresting or they are taking us to the police station, they are arresting. What I am asking, see, once this harassment is done, later we will come out because of the court judgment. As you have pointed out, can we file a case against the concerned sub-inspector of police who is the IO, that he has wrongly applied the sections, or we have to file the case against the government? Because every time it happens, we have met the SP, everyone, but they will say, sir, read about there, please adjust, it is only a formality. But once it is done, what is the section we can book the police under?
The problem is, I think this is the demand or dream of all the doctors, that we want to sue the police. But the police or any government authorities are protected by the section itself, that any act done in good faith by them, so they are protected and no action can lie against them. So this is, but you can certainly file a case, but again onus will be upon you to prove that they didn't act in good faith, they act with a malafide intent. So everything boils down to the proving of the case. In that case, you can sue the government, certainly government as an entity, but as an individual police inspector, it will be very difficult to file a case. Rather, I would say it will be very difficult to prove it that he didn't act in good faith.
No, sir. The only point is, once the doctor is arrested, it is evident a doctor cannot be arrested at the drop of a hat. But once the doctor is arrested, I am asking whether it is possible. We need not prove, it is already there. The Supreme Court has given the verdict, the doctor should not be arrested at the drop of the hat. But they are doing that.
The one case I can just quote, that on the insistence of IMA Pune, the concerned party put a case against Commissioner of Pune in that Dr. Tamane's case. And the Bombay High Court has given very strong observations against the police department. So we can do that, but it's very difficult. Practically it is difficult. Once in a while we have done it, and it has acted very well in Pune.
Yes, it is. I think perhaps it is the only case Naurenge sir.
Only case probably. So the doctor has shown the courage, though we go on, advising the same to everybody, but no, hardly anybody does it.
Yes, no one does.
But we can take them to task.
My request is whether the advocate Rohit sir can help in that.
I am certainly there to help. I am there. I go to court every day.
I think there should be a clause against doctors also, that acts done in good faith and not punishable. Like,
Yes, actually that may be the defense. Section 83, 84. I am open to correction in IPC. If you done something in good faith, then you are saved. And this section is applied generally when there is a death of a patient. That generally it is said na ki tu muddaun marla patient.
so thank you. Excuse me, we can No, no, we are really running short of time.
छोटंसं विचारायचं की आफ्टर टेबल डेथ किती वर्षांपर्यंत पेशंटचे रिलेटिव्ह तुमच्या विरुद्ध केस करू शकतात?
CPA मध्ये असेल तर 2 वर्षाचं लिमिटेशन आहे. 2 years from the date of cause of action. That is in this case from the date of death. Criminal or civil use. Criminal has no limitation.
You said now that you are supposed to pay some amount.
Now, just last moment, the CPA, the very important amendment which CPA has got, the madam has asked one question, where a patient can file a case. Now, previously, where the cause of action or where the has taken place or where a doctor carries its business, previously in that territorial jurisdiction court only the case could have been filed. But now, a patient from Delhi comes to Pune, takes any treatment and something goes wrong, and if he goes back to Delhi and again then to Meerut, who is native place, he can file case either in Delhi, in Meerut or in Pune.
Thank you, Advocate Erende. This topic of medical legal is ending. I'm sure you have many questions, but please ask them in person. Thank you very much for the enlightenment.
Thank you very much. Thank you.
My first time.
Sir, I'm foreign.
You want his CV? सरांची CV तिकडे आहे. काय जाऊ
I can just tell 9823370028 if anyone wants.
He's on Facebook.
I told them.
He's on Facebook. Friend request
All right, I think we are concluding this session. Thank you very much for your active interaction. Thank you, madam. Thank you. I thank all my speakers for their deliberation. And I think, as usual, the medical legal session has gone on longer than we expected. But thank you, Dr. Sundaram. Thank you, madam, for being there. And thank you, Dr. Kirkar, madam. Thank you, Dr. Kon. And thank you, Dr. Advocate Aaron. Anyway, thank you very much. Well appreciated. So thank you.
We now move on to our next session. Simulators have the ability to occupy an important position in flight simulation, traffic simulation, military training, disaster preparedness, etc. The field of medicine was not to be left behind, and perhaps the use of simulators in the field of healthcare is one of the finest uses of science and technology. I now invite Lieutenant Colonel Gunjan Singh to kindly come up on stage and carry on with the next session on simulation.
Good morning, everyone. I am Lieutenant Gunjan. I am posted in Command Hospital, Pune, and I am Associate Professor in Department of Anesthesiology in FMC. Moving from medical legal topic to simulation is a difficult thing. So training in anesthesia is basically relies on the duration and quality of clinical experience. It involves exposure to range of interventions. This works well when we are doing routine cases, but when an uncommon and life-threatening event occurs, the anesthesiologist needs to carry out multiple tasks simultaneously. This needs appropriate decision making and communication with others in the theatre. Simulation offers innovative and reproducible training experience. It enables standardized scenario building and reflective learning. Various non-technical aspects of an anesthetist's day-to-day work could also be addressed during such training. For this session, to start with, I now invite Dr. Sarita Swami ma'am. Ma'am, please come. Professor, ma'am. Sarita ma'am, CV. So ma'am is professor and head of department at Department of Anesthesiology at Bharati Vidyapeeth Medical College, Pune. I also invite Dr. Sarang Puranik. Dr. Sarang is there? Okay. So I think Dr. Sarang has not made it here. I invite Madam Dr. Sushma. She is Assistant Professor in Department of Anesthesiology and Critical Care in BJ Medical College. Ma'am, please come. We'll start now. To start the topic, I now invite Lieutenant Shamik Paul. Can I have the CV of Colonel Shamik Paul, please? Shamik sir is in Department of Anesthesiology and Critical Care in FMC as Associate Prof. Sir, please.
Good morning all. Excellent presentation by our previous speakers. I will like to take cues from the previous presentation and add a note while presenting simulation. Because simulation is not only what we learn, but yes, all medical legal aspects can also be simulated in a way we use our simulators too. With this, okay, so my presentation will have these following parts: a brief history, what the aviation industry taught us, like in human factors and classification simulators. We have a three presentation series, and I'll be covering what we were and where we are right now, and followed by two other speakers following what simulators are there in the armed forces, and thereafter the future. A small story. Anybody knows about this story? Lenore de la Salle was a 16-year-old girl who was found dead who was drowned in the river Seine in France. When the body was recovered, it was not bloated or ugly. It was very pleasant, as you can see. It was so pleasant that people fell in love with her. And then the French streets were covered with people, probably maximum attendance, to see the body when it was kept in the mortuary. Not only that, there were artists who put clay molds on her face and got this molds put in their houses. There were painters who painted her bust and the face and put it in the homes. Every home in Paris had her pic and had a mask on the rooms, on the houses. So this is a story that ends now, which will carry it after some time. So, coming to simulation and its history, right from 2200 BC, there were clay models of various parts of the body that were used to explain people of the anatomy and the management of patients. Here, 18th century, we have this obstetric simulator, which was made. And the first modern simulator was there by Georgie and Georgie, a father-son duo. And it was primarily for teaching obstetric cases and how a fetus can be taken out without much of a damage, and this caused a significant reduction in maternal mortality as well as fetal mortality. Now, John Lind and Esmond Lateral. Now we come back to our old lady of Siam who was found. So I'll continue the story from John Lind and Esmond Lateral. Now, John Lind was a Norwegian anesthesiologist who pioneered in the process of resuscitation along with Safar. So I'll talk about him later on. And he convinced a toy maker, Esmond Lateral, to make something which might save a patient's life by simulation. By the way, Esmond Lateral was a toy maker who was initially into books. He used to start making wooden toys. Then Esmond Lateral, what he did was got hold of some plastic, that is post Second World War, or during Second World War, around 40s, and he started molding toys out of plastic, and he was one of the best toy makers in the Norwegian history. Okay, and also in France. Now, Lateral had a history to himself. he made a beautiful toy who he named Annie. Now recently Annie has not come back into place. He renamed the toy Annie. And he had his 2 or 3-year-old child who had a drowning and almost died, and Lateral saved him. So that was Lateral's history. John Lind, along with Peter Safar, came to Lateral, asked him to make a toy that would save lives. This unknown girl had a name. Now it is known as Annie. And Lateral put this face, which was stuck in the walls of France for a century, on the face of the toy. And it was named Annie. Annie, why? Because first of all, nobody like to do a mouth-to-mouth on a male mannequin. There is a lot of resistance amongst male doctors. It is primarily a male-dominated society. So Annie there was, and Annie was given a name. By the way, she is the most kissed girl in the entire world, saving up to 2 million lives. So, and Peter Safar, pioneer of CPR, with Lind, Dr. Lind, and of course Lateral, was responsible of what we know as CCNE today. That is the beginning of simulation, right? And then came Michael Gordon, MD, PhD, who made this Harvey, which is capable of simulating various cardiovascular conditions, varying hospital findings, blood pressure, and etc. in 1968, followed in 1969. Now the rapid development takes place. Simulator 1, SIM1, by Denson and Abrahamson, and it was used to simulate the induction of anesthesia for the first time. Comprehensive Anesthesia Simulation Environment, 1986, by David Garber. It also was an advanced simulator of that time, and then the genesis of simulators took place in all fields of medicine, from endoscopy, zeoscopy, colonoscopy, and this is the year-wise how simulators developed. Now coming to aviation. True, aviation industry has been using simulators because aircrafts are very expensive. You can't train pilots on the aircraft, to train off the aircraft and learn them, teach them how to fly. Simulation was an integral part of avionics from the very beginning, and we have learned not only simulation but many other things which I'll come to right now. Before this, these are small data from the United States of America that states that preventable medical errors are believed to be one of the largest cause of death in the United States. This is about a decade old data, right? About 400,000 deaths per year. That's a huge number. And iatrogenic injuries result in disability of approximately 3.5 million patients per year in the US. That's a huge number. It has also been said by this model that for 600 non-reportable incidents, 30 gets reported eventually. There were 10 accidents which happened in the 600 and 1 fatal accident. Our role as anesthesiologist and as a perioperative physician is to search for the one case that either spoil your career, break it, or make it. And we are in search of that one case every day in our life when we work in the OT or in the ICU, right? So a lot of theories were proposed how to prevent an accident, and there's something known as human factor analysis and classification system. This is done in avionics also. So there's this dominoes theory, right? The old Indian cricket team, when one player goes down, everybody goes down, and you have all out in 10, 100 all out. So that is dominoes theory. One thing leading to the other. The environment, wrong worker choice, unsafe behavior, accident, and injury. So who was responsible for the best batsman, the best all-rounder? We don't know. So we have a better system than the Swiss cheese model. The Swiss cheese model has been followed world over in avionics. It is to ascertain who is responsible for the crash of an aircraft. The punitive action, is it for that particular doctor, particular pilot who caused the aircraft, or the environment as such? So what is Swiss cheese? What is cheese? Cheese has a lot of holes. Each hole is a potential life-threatening or potential accident-causing factor. And every step of an accident has got 4 layers. Unsafe act, the preconditions that led to the unsafe act, unsafe supervision which led to the preconditions and organizational factors. And when these holes or preventable holes align in a straight line, then only an accident takes place. That's what avionics tell us, that's what aviation tells us, and that's what we follow here in medicine too. Now if you break down the human protective system, the human factors are very important, and that's what we talk about it, not only doing CPR in Annie, but to have better crew resource management, to train our people, adverse mental conditions. Everything has got a role for a patient outcome. So Unsafe Act has got various parts as errors and violations. I won't go into detail, but errors are different, violations are different. The preconditions may be substandard working conditions of operators, adverse mental stress. Maybe he had a fight with his wife, so he's angry, or maybe his child is not well, so he's in this condition he's working. Substandard practice of operators. Was he trained? Was he not trained? Was he trained inadequately? Unsafe supervision is also important, and over and above organizational influences like human resource management, crew management. So all these are responsible, and there's a hole in either of this model, the death or an accident will take place. Sorry. So when we integrate our Swiss cheese model into the practice of medicine, we see, for example, like there's a death in the MRI. We just had a discussion about death in the MRI. So who's the responsible doctor? Were there any protocols in place? Were there anesthesia machine, MRI compatible machines in place? So everything has a role. And if we divide our judgment and our line of investigations in these following parts, whether it is unsafe tax supervision or anywhere else, we can come to a diagnosis or maybe a reason why that action took place or why that took place. And Swiss cheese model is there. Swiss cheese model and its applications are also a very important part of simulation. Now coming to the classification of simulators. It has been time that the simulators have evolved from what Resusci Annie was, initially a small toy that was used for CPR, to various type of present day simulators, which can be either compiler driven or event driven. In event driven, we do have a standardized patient care actors, hybrid simulations, and computer based simulators. These are integral programs with safety features which can simulate every condition which is responsible for the betterment of a patient or the patient going down. And the computer-based simulators which are in today can further be divided into these three parts: the low fidelity simulators, the medium fidelity simulators, and the high fidelity simulators. The low fidelity simulators are cheap. They can be used extensively for training of students as well as nursing staff and doctors, and they have got either screen-based text simulators that has a haptic feedback and also static mannequins. And medium fidelity, we have got screen-based graphical simulators and mannequins with mechanical movement that can simulate the breath sounds, the breath, the pulse rate, the pupillary dilatations, constrictions, or the drugs acting through a barcode. And then there are high fidelity simulators which are non-physiologic static programming and based on an algorithm. So we do in the Armed Forces Medical College to have the medium fidelity and high fidelity simulators, also over a numerous number of low fidelity simulators. To deliberate upon this, I would like to invite Colonel John, who is assistant prof in anesthesiology and critical care department of the FMC, to come and show the simulations which we carry out for training purposes for students and paramedic staff and doctors in FMC.
Good morning, everyone. After the very informative presentation by Colonel Shamik Paul sir, I'll be dealing with simulation anesthesia in armed forces. Although my topic is simulation anesthesia in armed forces perspective, but I'll be covering the other aspects of simulation which we normally carried out in our training center and pertaining to armed forces only. So, as we all know, the simulation is defined as any artificial representation of the real world to achieve an educational goal. Basically, it is also kind of learning only. And any educational activity involving the use of simulated situation as opposed to live patient can be also defined as a simulation scenario. For example, any case-based discussion, which normally happen inside the OT or in ICU also, between the consultant and the students can be regarded as simulation. The best and most successful examples like the American Artisan Accredited BLS and ACLS courses, and the American College of Surgeons Accredited ATLS courses with the examples for simulations. Like we have various types of simulation, we have various levels of simulation also. Like micro simulation, it is basically focused on the needs of individual clinician. Like it basically consists of basic motor skills like suturing, intubation, mask holding, and we have meso simulation, which focus on higher cognitive skills and behaviors, and macro simulation, which focus on the entire organization. If you go back to the history, during 1970s, the simulation healthcare started gaining recognition, where the aim was to limit human error and improve patient safety. As Sir has rightly mentioned, the medical simulation also took a lead from the aviation industry, the nuclear industry, and from NASA. NASA, one of their retrospective analysis, they found that the 70% of their errors were due to human factors like failed interpersonal communication, decision making, and poor leadership. By inculcating the simulation in our training, we can improve the interpersonal communication of our practices, and we can improve the decision making, and we can make a good leader out of it. So there are certain common simulation platforms which is pertaining to armed forces also, like PARTAS trainers, simulated patients, simulated environments, computer-based systems, integrated simulators like Sir has mentioned, and virtual reality and haptic systems. So I'll be focusing on these PARTAS trainers and simulated patient environments. The PARTAS trainers, it's basically focused on the particular task, like the airway management, intravenous access, bladder catheterization, suturing, and all. The simulated patients, it's very important as an armed forces point of view, because here what we do, the medical cadets themselves may become patients or doctors by turns. Okay, if you see these pictures, there are the medical cadet is carrying a colleague, and in other pictures, the two people are carrying one patient. So you have to simulate all these scenarios, because when we as a doctor we go to field, or our paramedics go to field, there is no way you have to get an easy ambulance or access to the evacuate the patient. So if you have a buddy system, in army we have a buddy system. The one buddy is responsible for the other buddies, for each other. So if anything happened to the buddy, he is supposed to take care of him. How he is take care of him? Either if he is injured, he can carry himself, or with the help of others, we can shift from one place to another. Simulated environment, it is very important. It gives adequate time to plan ourselves for advanced planning, and it helps us to train all the personnel, including the low-level staff, housekeepers, and it inculcates the teamwork, and it will allow us to delegate the roles and responsibilities, and it also facilitate us to highlight the deficiency that can be addressed before the real patient arrives. Okay. In army, what we have to do, we have something called disaster drill. We keep conducting regularly. The advantage of the drill is, so everyone should know, in case of an emergency, like we are getting a mass casualty scenario or any blast injury, there are multiple casualties, gunshot wounds. So how do you go about it? Everyone should know their roles and do's and don'ts, and in that moment, including the low-level medical staff or the house staff, he should know what should I do in case of any mass casualty comes to the hospital. If we keep simulating these incidents and environments, we will never go wrong. Like I will give you a small example. When I was posted in UN mission in Congo in 2017, we received one of the highest casualties in the history of UN. There were around 15 fatal casualties and 33 gunshot wounds. We got a message at around 3:30 in the afternoon. There will be 33 casualties will be coming within half an hour. So we were mentally prepared, and we were training it thoroughly. We know the situations, if patients come, what to do, where to shift the patient, how to activate the OT. Within half an hour, all the elective patients will have been shifted to other wards, and the ward was ready OT was ready, ICU was ready, and the entire scenario, the 33 patients come within a span of 30 minutes by multiple ambulance and air ambulances, and within 30 minutes we were able to handle all these things very smoothly. One person was standing in the emergency and he was doing the triage, and the priority 1 patient is going to ICU and OT, and it was very smooth run. Unless until you practice this, you will not able to do it. And like this computer-based systems, like the robotic surgery and the integrated simulators. These are high-fidelity simulators which we have in our FMC, and it is most closely resemble a real patient. You can simulate almost all the scenarios in this, and the only disadvantage is very expensive. And we have virtual reality and haptics also, where you can simulate the virtual scenarios. In army, there is a say, the more you certain time of peace, the less you bleed more. It is applicable to simulation also. If you train your subordinates, if you train your colleagues, if you train your paramedics, and once you go from this place to field, they will be able to handle the cases, they will be able to manage the cases very well. So, why do we need it in armed forces? Because we see the terrains, these kind of places where we serve from, unfamiliar and difficult terrain, hostile environment. You know who is your friend, who is your enemy. And there is a constant threat to our life of medical personnel. It's not the serving soldier who is wearing the bullets, it's the medical persons also. Because you never know. One is the terrain part, the climatic conditions, the other, the enemy's bullets. It can come from any side. And the infrastructure concerns. Can you imagine evacuating a patient from this kind of terrains? This is one of the posts where I served in 2007. If anything happened to the serving soldier, how do you evacuate the patient? There is no ambulance available. Sometimes we have to carry the patients almost 14-15 kilometers by road. And certainly there is a logistic limitations. You don't have ambulance, you don't have any road access, you don't have any communications. So everything you have to plan. Unless until you don't plan it, you can't manage the cases. And what is our role as the Department of Anesthesiology, particularly FMC? We are given the task to train maximum medical cadets, young medical officers, nursing cadets and officers, paramedics and other combatants, and basic aim is to sharpen their basic clinical skills. We are not teaching them any rocket science. The basics should be very clear. For that, we have to train them due simulation mode, and they should know how to tackle combat trauma and high altitude illnesses and save maximum lives under austere circumstances. So the heart of their simulation training is based on our clinical skills lab, which was established in the year 2003. Initially it was located in the, if you come to FMC, it was located in the Golden Jubilee building adjacent to the department. Later on it shifted to main building of FMC in 2013. And now it is located in the Premier Hall from 2017 onwards. So these are the various courses conducted regularly in our skills lab, like a PLS, ECLS, ATLS, the ATCN course for the combat nurses, and the military medicine models for the cadet who is passing out from our college, and for paramedics and nursing cadets, and the NALs and PALs. This is an inside view of our AFMC clinical skills lab, and we have dedicated stations for structured courses like ATLS, and we have our dedicated human volunteers for ATLS Malaj, and we have a dedicated station for BLS, ACLS, as well as the neonatalization program and PALS, and for airway management here, starting from mask holding to fiber optic intubation, we can simulate any situation and train our residents as well as the medical cadets. This is a human patient simulator which we got installed in 2004. We fondly called him Pandura, and some people call it the Pandurangan because he family. And so it is a high fidelity simulator. It can simulate all types of emergencies. I'm very sure all the residents, all the faculty serving or retired, all have undergone through some sort of training. Even myself, I have undergone some trainings in this simulator. So it simulates all these scenarios, and it is one of the best simulator I have ever seen. And like sir has mentioned about Annie, we have the latest addition to our clinical skills lab with lateral Annie with a sim pattern monitor. It's a medium fidelity stimulator capable of multiple procedure. You can auscultate the cardiac murmurs and breath sounds and arrhythmias, and it's normally used for conducting the workshops and all. And with this simulator, we are I am the co-worker for this project. We are planning to conduct a study for using this simulator and involving various medical cadets of various the levels. Apart from that, we have laparoscopic cell simulator for the surgeons. And what we do in armed forces, we have scenario-based training. We conduct teach them how to manage the combat trauma casualties, and pre-deployment training to young doctors and paramedics, that is very important, and management of high altitude illness, and transport of critically ill patients by road and air. Treating the patient is very important, and as well as transporting the patient is more important. So scenario-based training most commonly conducted in every small units, and basically a small group of teaching conducted by either the regimental medical officer or the specialist. Most of the time it is anesthetist only. And normally we conduct BLS, ACLS, ATLS, NRP and PALS. The spectrum of injury is totally different in our armed forces. Okay, so we also train them to manage combat trauma and disaster situations like gunshot wound, you can see, and multiple gunshot wound, the road traffic accident, and the burns, earthquakes. So pre-deployment training is also very important. You can't ask a person to pick up your bags and go to China border or Pakistan border. So you have to train them before you induct the particular doctor or trainee or paramedics. You have to train them properly. So it is also an integral part of combat medical support. It plays a pivotal role in training, and it also inculcates the teamwork. Imagine when you are as a RMO, regimental medical officer, you are going with the infantry unit in a forward place like JNK or Arunachal or somewhere in Chinese border. So there are 1,000 people, 1,000 soldiers including officers, and one doctor. So, and there are 10 paramedics. So you have to train your paramedics. You can't. One doctor cannot go each and every person to meet and what's their problem and ask. So you have to train your paramedics. So through them you can manage the cases. And when you are pre-deploying, you have to teach them how to treat the patient, how to evaluate the patient. As I said, treating is very important and evaluation is more important. Whether the patient is fit to transfer, if he is fit to transfer, and how do you optimizing during the transfer, how are you planning to transfer him by road, by air, is all very important. And you won't get any kind of, as an anesthesiologist, when you get posted in field, you won't get any high fidelity machines like G, Wipro. You'll get the basic machines only. And sometimes you won't get any oxygen also. So you have to familiarize with your equipment, and communication, as I said, there is sometimes you won't able to communicate with your seniors or with your colleagues. So these are the points, very important. And management of high altitude illness like HACO. I'll take 2 minutes. Have you all heard about that incidents of Hanuman Thappa who survived in Siachen Avalanche for 6 days? It's not happened. Normal person can survive for 6 days under the snow. So later on he died. That's a sad story. The transport of critically ill patients by road and air, it's also very important. How to unload the patient, how to load the patient, how to monitor the patient during the transfer, and how to stabilize the patient. It is all very important. Apart from that, we have competency-based undergraduate curriculum also. As you have noticed, we have 10 topics in anesthesia and 46 competencies, and we train the undergraduates in the skills lab as well as in the human patient simulator. For the medical cadets, when they joined in our college, the first thing what we do for the foundation course, hand washing, first aid and basic life support, like then basic airway management. When they reach the 6th and 8th terms, we teach the skills like airway management, mask holding, and insertion of supraglottic airways and intubation. For the undergraduate in the final year, the military medicine model, and now all the cadets who are passing out from the FMC or BLS, ACLS trained. We made it compulsory. And a few words about the military medicine model. The 3 weeks long course for the passing out batch during the passing out parade. Basically, it helped them to transit from medical cadets to young officers. Finally, they have to become officers and go to field to serve with infantry guys. So basically, it is a various academic and non-academic topics will be discussed. So kind of interactive sessions with the panel of residents and senior faculty. For postgraduates, all the postgraduate students who is passing out from FMC are trained in BLS, ACLS, ATLS, and some are which are interested in NALS and POLS also can be done. And they are all trained in the human patient simulator also. And some of them are instructor in ATLS and BLS, ACLS also. We also conduct the regional anesthesia workshop using the cadaver as well as the blue phantom. As I said, you have to train your paramedics, nursing cadets. It's very important. They are your backbone. So they are also undergoing the same training as the medical cadets, BLS, ACLS, airway management, suturing, transport of patients. We also take care of our students from various friendly nations. COVID, we all know about what COVID had done with us. So FMC took a front lead to make SOPs and protocols, and also various educational videos for donning and doffing. And almost all our faculties and residents, those were posted that time, based on various parts of the country under the DRDO hospitals. These are time we have devoted to simulation-based skills training. For undergraduate, it is 12 hours per month. For postgraduates, it is 8 hours. For nursing cadets, it's also 20 hours, and paramedics, it's 10 hours per month. The problem is not bad people in healthcare. It's that good people are working in a bad system that need to be made safer. So simulation, via simulation, healthcare it limits the human error and it improves the patient safety. To conclude, simulation-based education can appear threatening for trainees, not only trainees, for the trainers also. So sometimes we are worried about the outcoming, shortcomings, and we are worried about to expose their shortcomings before our peers. But we have to undergo this. There is no escape to that. And the trainees expect the trainers to be sincere and to be interested in their development. And trainers also need to be encouraging and supportive of the learners.
The basic idea about we taking up simulation was, as a topic was, over last 2 decades we realized that whenever you talk about simulation, the basic, the thought which comes to a young anesthesiologist or young resident is a high fidelity simulator with monitors and machines. 90% of things you are not able to fathom what is happening, but it has evolved in last 2 decades from becoming such costly simulators to very low cost simulation, which depends absolutely on the creativity and the thought process of the trainers. To talk about the future aspects of simulators, I now invite Colonel Shyam. He is an alumnus of FMC and has done his DM in intensive care from AIMS, Delhi. Come.
Thank you. Thank the organizers for inviting me. and very good morning to all of you after having such excellent presentations. And when we talk of the future of simulation, my perspective, the first disclaimer is these are my personal views. And the reason why I say that this is my personal view is not that we've gone through literature, all of us go through literature. But what I want to say is, this is my viewpoint on where literature is heading to in simulation, where simulation is going to in other parts of the world, and what is it that we are going to get out of simulation. Now, if I take a simple hand poll in this audience, how many of us got trained on a simulator in our post-graduation? Can I please have a show of hands? Barely. Okay, now I was one of them who underwent the training. Okay, so let me put up my hand, my colleagues. Now I have to ask you a question. Did you really benefited out of it? At our time, 2007.
Absolutely personal. I always believe that the maximum amount of simulation for which commercialization is done, to basically focus for the first one. The amount of patients which we get, we practice, we actually don't need high fidelity simulation. We need more low fidelity.
Yes, so precisely. So this is the perspective with which I had started searching the literature. Exact perspective. I mean, इतना patient है, वो simulator को लेके आके उसको करना. Do we really need it? Is it possible? Will it be of any benefit? So we in the armed forces, of course, we got a very different perspective. You go to a place at 17,000 feet and you are alone with 20 people cut off in winter. You don't know what to do. The last time I faced this situation as an anesthesiologist is when I got a call from somebody who was stuck like that and the patient was having a VT. So this was 2014. So I said at that time, within the simulation, nothing was there. So I said, you take a picture of the ECG on the WhatsApp and send it to me. And I told them how to defibrillate. So the doctor there, he knew how to defibrillate, but he did not know how to exactly manage that. It was a transcutaneous pads. He did not have a proper, metal defibrillating pads. So we clicked photographs, I showed him what to do, drew it. So we managed. That's our perspective. But is it applicable? So this is the perspective. Do we need it? So my idea is the nuts and bolts of the system. When I speak of it, it is the physical infrastructure, as in you got a high fidelity, medium fidelity, low fidelity simulator. Those are the nuts and bolts of the system. They are merely the physical building blocks of anything. The real questions are, can and should we integrate this into medical education? Ultimately, simulation is a modality of medical education. So should it be part of curriculum? And how should we employ the tool? Is there any advantage of simulation over traditional teaching? What are the methods and methodologies used for training? Who will be the trainer? Now this question, from my perspective, probably is one of the most difficult questions to answer. And how do we train the trainer who is about to use that simulator? And what are the brains of the next generation of the simulators? Now, so as I said, the first disclaimer, these are my personal views of viewing literature. I leave the audience to their own wisdom to view literature in their own light. So as late as 2014, this is from the BJ. Simulation-based anesthesiology meta-analysis says it is better than no instruction at all, which is not very difficult to understand, but it is merely non-inferior to traditional teaching. So in 2014, BJ says this. From here, we've gone here in 2016. So in the NHS in UK publishes a document in 2016, and the executive summary, the first two paragraphs, there is good evidence that practical procedures can improve patient outcomes if taught using simulation-based education. And what practical procedures they were talking of? Decompressing a pneumothorax, doing thoracentesis, putting a pericardial drain, doing central venous catheterization, doing endotracheal intubation. All life-saving skills that we are all expected to know and which we all have learned on patients only. Let's be honest about these things. And then there is also reasonable evidence that non-technical and human factor skills required by core medical TCMTs, core medical techniques can be effectively taught using simulation-based education. So the same country, predominantly 2 years back, says in a meta-analysis, maybe we don't need it, and 2 years later, we get an NHS guideline that it is good. Then, in 2020, there is this national program in Denmark, where they have made an advanced airway management for anesthesia trainees using simulation. You see the range of techniques that have been taught. Re-intubation in the prone position. What do you do when the patient is on the floor? Emergency cricothyrotomy. How do you pass an endotracheal tube through the supraglottic airway? And how to manage the intubation team. So the worst and the most difficult topics in airway management have been taught in a national government-sponsored program in Denmark. So from do we need it to how best we can use it, this is where literature in the world has progressed and simulation has progressed. So now the question is, do we need it? Question is finished. Question is, how best can we use it? Ultimately, money will come into the system from the government or in private practice. Okay, and when you undergo accreditation of ACLS, ATLS, somebody will put up a program for DAS accreditation. Difficult Airway Society, we will do simulator-based accreditation. So money will come. Question is, how best do we use simulation? Now, we also individual training, what my colleague John had spoken earlier. These are all individual training. You teach a person how to do CPR, he is doing CPR. But if you go back to the Swiss cheese theory of doing things, so unless there is a systemic flaw, medical error will not translate to patient harm. Okay, so now, this study was there in New York, this simulated cardiac arrest situation. What they did, except for the ICU and the OR, where people are trained to manage, they simulated cardiac arrest everywhere in the hospital. And what they've done is, they've seen how the system responds to simultaneous arrests in multiple locations in the hospital. So they found, and this is to put latent threats, things that you don't imagine to be a threat. I'll give you a simple example. You got a call for a cardiac arrest in this room. We all are here. We do CPR. We take the patient. If this door does not permit a stretcher to go out, what good is your CPR? You cannot maintain the patient on mouth to mouth. You cannot keep giving CPR for time eternity. So this is a systemic threat. Okay. Similarly, they identified 106 threats in that one. It's a single center, one hospital, one simulation, 106 threats, out of which 4 were deemed to be imminent. That is, they will kill the patient immediately. And 15 were high risk. If they will not kill now, they'll probably kill in 1 hour. So, to identify a systematic weakness, it is not possible without the use of simulation. You put a stress on the system and you see how the system responds. But for this, you have to be forthcoming enough to say, yes, we are deficient. So the needs assessment should be very, very thorough, and we should be very frank about what our weaknesses are. Then the other way where simulation is being employed is how to see whether human variability, we are all different. If we are put in a stress situation, all of us are expected to react differently. How will our personality variability, suppose we all take a personality test, somebody is there to assess ये personality के लोग, when they are put in a stressful situation, they will respond favorably, somebody will respond unfavorably. So choosing the best man or woman for the job, matching people's personality to the job, you cannot do it without simulation. Okay, and then of course we all know what COVID thing. No medical conference is complete or lecture is complete without what COVID did to us. So these people have done a survey in COVID-19. So they have found that 70% of the people who were doing simulation training, they went to distance education. That is distance simulation training. And 82% after ending of the pandemic, they plan to keep a hybrid model. That is, we conduct both live and both distance simulation education. So the way simulation is expanding is actually in a very, very exponential manner. So again, we come back to the questions. How best to employ the simulation technique? So when we talk of this, we talk of theories, methodology and methods. Okay? And when we are saying training, who are we talking of training? We all saw you're training undergraduates, you're training nurses. Who is training the trainers? When I went to the METI simulation in my college, I realized I could not even negotiate how to switch on the machine properly. This is honesty. It's a high fidelity simulator with a lot of computer programming. And every time we used to switch on the simulator, it used to be a very, very difficult thing for someone to actually use that simulator. So really, I mean, and are there any ethical issues? So let us see. So when we talk of theory, we talk of theories of learning. Okay, there are lots of theories of learning. There's directed, self-regulated learning, mastery learning. So what is the practical implication? How well can we integrate simulation into curriculum? At what level should it be introduced? Undergraduate, postgraduate, subspecialty training, or we make it mandatory. You have to undergo 10 simulation sessions in a month, otherwise you will not pass. You will not be accredited. Should we do that? How frequent? Can this be a tool for measurement? Should you or should you not credential a person that he or she is fit to undergo an MD if they fail on simulation? That question, ultimately these are the types of questions that are going to come. And are my measurement tools valid and adequate? Suppose I say that this person has performed poorly on a simulator. If you ask me, if you send me for a simulation session, I know that that patient is not at risk because it's not a human. Will I perform well on the simulator? If I'm performing badly on the simulator, can you say that I'll perform badly with a regular patient? Maybe not. But who decides this? So is the measurement of simulator-based competency valid and adequate? So these are the questions that we all have to ponder. Okay, and this is what is going to come. The more you put simulation into medical education, this will all come. So methodology, when we talk of methodology, what really do we want for the simulation to solve? Procedural based training is the traditional way. You want to put an IV line, you want to put a central line, you want to probably do some suturing, that's okay. But things that you cannot train on, multitasking, communication between team. You tell a sister to give epinephrine, she says, I didn't hear it. She's not trained to hearing it. She is more fixated on when her shift will end and what routine she has to finish. This is a practical problem. So multitasking, communication, team task, and relation between cognitive workload and problem solving ability. If your cognitive ability is low, then and there is a complex situation, you may not be able to solve a problem. So all this will come through simulation. And where are we doing this? In situ. When I say in situ training, that means you put a mannequin or you put a simulated event within an ICU, within a real working ward. So in a skills lab, there is no patient, there is no situation going on. Okay? So where do you train? So these things have to be answered. So in situ training is a big thing. You put a real event in a working ICU, and the people who are working in the ICU, they will have to disengage from their tasks and do this. Which actually happens. If you've got a cardiac arrest, people will leave their task and come. Correct? Now, then the next thing that is there in the future. How are you collecting data? So now we are all into virtual reality and eyeglass tracking. You put on a Google Glass, there is a study in pediatric airway intubation where they saw that when the intubation is going on, where are the eyes of the team members looking? So they saw that almost 30% of the time of the team is not focused on the patient, it is focused elsewhere. So you see that, the frightening amount of data that is being collected from us during simulation is what we all have to be aware of. Will you be credentialed on this? You saw 35% of your time away from the patient. You will not be credentialed. You are not going to get your next increment. This is coming. This is coming. I don't mean to fearmonger, but we have to understand the implications of automated data collection. Virtual reality. So this virtual reality, they did a ALS training in Japan, where they saw that virtual reality ACLS training is as good as traditional ACLS training. So you go on to virtual reality, and this virtual reality service was not even controlled by the doctors. It's a commercial VR service. It is like the drone pilot flying from the US and pressing a button and immediately people die on the ground. This is what is there in medical education. It's coming. Okay, and they said that if you do a VR CPR training, Spanish study, it will improve your theoretical and practical skills. Again, who will credential the simulation trainer? They did a survey in this journal called Simulation in Healthcare. These are the curriculum that we are all supposed to know if we claim that we will train somebody on simulation. Is it? I mean, really, just take a look at the list. Are we really credentialed in all this? Who is going to credential us? Who will train the trainers? And these are the core competencies that we are supposed to get if we are supposed to sit in simulation training. Debriefing, most important. Once you've done, there is a survey form circulating. How was this lecture being conducted? These are all debriefing. So unless your debriefing is excellent, you will not get anything out of simulation. Okay? And the last and the most, from what I see, who drives the machine? Okay? Now, there is this study from this, I think, was a Danish study in 2019. What they did is, it's a Canadian study, sorry. So there's a group of neurosurgeons from the McGill University, Department of Neurosurgery. They said, they made a checklist that when you're reviewing the literature on virtual reality in simulation, in medical simulation, what is the quality of literature published in computer science journals? What is the quality of literature published in medical literature, in medical science? They found that the comp-sci literature was better in study design. So you see, actually if you see the future, simulation to a large extent, what I see, disclaimer, it will go out of the hands of doctors. We have to learn how to work with non-doctoral people. Okay? This is the future. I mean, let us accept it. And now, who will be the stakeholders? Why I showed this slide, the penultimate slide, promise. JMIR Serious Games. This is a gaming journal. It is the application of gaming and gaming-like situation to medical science. And this is the impact, it's not a bad impact factor, 3.36 impact factor, and a 5-year journal impact factor is 4.3, quite good, probably much better than a lot of anesthesia journals. And if you see the editorial board, only 20 to 30% of them are medical doctors. Rest of them are engineers, psychologists, behavioral scientists. So actually, if you see the progress of simulation, you see the amount of interdisciplinary coordination you have to do is going to be enormous. What is going to be brought to bear on us, we have to be prepared for it. And just a small sample of ethics. Haves and the have-nots. I trained on a simulator, you did not. Probably, are you worse off than me? Haves and have-nots. In situ training. You simulate an event in the ICU, the staff is leaving the patient and attending the simulation. Everybody knows that simulated patient is, or that simulation is not going to die. If you don't perform, management will see you as a poor performer. But can the other relatives question, what were you doing leaving my patient attending a training event in the middle of an ICU? Will simulation impact the doctor's sensitivity involved in intimate physical examinations? You would examine a female patient as a male doctor. I cannot touch any female patient without the presence of a female attendant. If my training goes on to simulation, will I lose the sensitivity of an intimate physical examination? Where will my moral compass go? And now this, never the first time on the patient, this is by the French Health Society. This is a real document that they have put out in 2020. It says that you should not perform any surgical procedure on a patient for the first time. You have to first do it on a simulator. So is this the new primum non nocere? You cannot learn on a patient. Believe me, all this is going to come. It is only a matter of time, and the people who will be dictating it will not be doctors. It may be lawyers, gamers, philosophers. And I mean, this is the future. So simulation, in my view, in my personal view, again, is an evolving science, and it needs evolutionary change on our behalf too. It's just not that the world is evolving, that no, we have to evolve, adjust, probably learn a little bit of gaming and virtual reality. No, it's a joke right now. Before the pandemic, if you see the pandemic, what digital change was supposed to be brought in 10 years has been thrust upon us in a matter of one month, 6 months, maximum to maximum 1 year. Who imagined all this? And hardware is only a small part of the system. It is the human behind the machine which is more important. Who will be that human? What direction will he or she take the machine in? That is, to me, this is the future of simulation. It is not about the machine, it's about the human factors and the interpersonal relations and how team management is done in simulation. Thank you for your time.
Thank you for all speakers for excellent presentations. Actually, I like to share our views because we also have a high fidelity simulation lab in our institute. From this year, from JR1 batch, we have started all regional techniques and airway techniques first on simulation, and then we are giving them on patient. But we feel a palpable difference in their techniques, and especially regional techniques. Even spinal epidural, we first train on the simulation and then we are giving them on the patient. But I think, as sir told, the training is we received from non-medical persons, that is engineers, IT engineers. But how to use it and what effectively we can use it, it is depend upon again the faculty which we are training for our students. But especially this is useful in rare scenario like cannot intubate, cannot ventilate scenario. We cannot teach on the patient. So how to act within the time we can teach on this simulation. This is my view. So thank you very much. I will not take much time.
I completely agree with you. This is how simulation began. You cannot simulate an air crash. That is where simulation began, that industry. You cannot teach CICV, you cannot teach pericardiocentesis on a live patient. You have to do simulation. But the question is, has simulation stopped there? The answer is not. So to what extent is it going? Where is it going? Who will provide the direction to the technology? I think unless we game the scenario in our mind, we will not be in a position to even, suppose today we say that if you're not credentialed on a CICV mannequin, you should not attend a CICV patient. Is that possible? So these are the conflicts that arise. So thank you, ma'am, for your perspective, and I really agree. These are how things are.
Thank you.
I now request the chairpersons to kindly felicitate our speakers, Lieutenant Colonel Shamik Paul, Lieutenant Colonel M.K. John, and Lieutenant Colonel M. Sham. Dr. Suchitra Nikam and Dr. Roshan Ranade to kindly felicitate our chairpersons, Dr. Sarita Swami and Dr. Sushma Tandre. I request the chairpersons to felicitate Lieutenant Colonel Gunjan Singh. Kindly note, tea is being served outside, but due to time constraint, we'll be continuing with the next session.
Moving on to our next session. Airway. A single word to make an anesthetist get up from his comfortable chair. Such is the power of this concept of airway management. On that note, let's meet the airway experts in our next session, for which I kindly call upon our chairpersons, Dr. Anand Bhatia sir and Dr. D.D. Bande sir. Dr. Anand Bhatia sir is a very senior anesthesiologist and he is also an HOD of KM Hospital, Pune. He has many honors and many publications. He was a guest speaker on topics in high-risk anesthesia, transplant anesthesia and critical care. He was also a national conference speaker. Dr. B.D. Bande sir is also a senior consultant anesthetist in Noble Hospital, Pune, and he has also many honors to his credits. I request chairperson to kindly.
So good morning again, and with a very excellent session from our armed forces colleagues, whom we are really proud of. We move on to another area of expertise, and that too from the none other than Dr. Jiggy Diwatia, with whom I have been working in ICCM for the last 30 years, and his scientific and organizational achievements are numerous. He's been on anesthesia side, been recently editor, and if we are fortunate, we'll also see him as a president of ISA in this year. On ICCM side, he had held all the positions possible right from beginning, member, secretary, followed by president of ICCM at national level, as well as on the academic side, he's been chancellor. And regarding his publications and affiliations, of course, we all know that he's attached to as a HOD and a director in prestigious Tata Memorial Hospital, and now also having additional responsibilities in 2 centers in north of our country. And he's been associated with All India Difficult Associations, and it's a proud moment for all of us that All India Difficult Airway Associations documents have been included as part of formation of American Society of Anesthesia guidelines, and Dr. Jiggy Diwatia has been an active part of the team for that, and he's going to speak to us on the same topic. The intubation or airway management in the intensive care is little different than from the operation theatre care, and I'm sure he's going to enlighten us on those aspects. Taking the stage, Dr. Jiggy Diwatia, it's yours.
Good morning. And thank you very much, Dr. Bande, for that very generous and kind introduction. I want to thank the organizers of PROACT, and especially Dr. Pratnya Bhalerao Madam for inviting me and accommodating me over here today. And it's a great honor to speak here, especially in front of my teacher, Dr. Khon. And so I will be speaking on tracheal intubation in the ICU, right? Now, this is, when we talk as anesthesiologists, we talk about tracheal intubation, it's something like second nature to us. Right? We do it every day, we do it in and out, and by and large it's not complicated, and most of the time everything goes off smoothly. You put in the occasional tube in the esophagus, nothing happens, you pull it out, you put it back in. I know things go on reasonably well, and this was the National Audit Project 4, which was done in the UK between 2008 and 9, and they looked at all the airway disasters that happened in all the NHS hospitals in the UK in that 1 year. And there are only 184 complications which resulted in death or brain damage or ICU admission or something like that. Okay? And so they found that the incidence of difficult airway was 1 in 22,000 anesthetics, but the mortality rate was only 1 in 180,000. So, not a huge mortality and that sort of thing. Okay? As you heard from the previous talk, I think there are a lot of other lessons that were to be learned. was that the elements of care were poor in 75%, and obviously there were some issues either with training or the reaction of people or the way they handled a crisis in that situation. But so when people are stressed, when patients are sick, then maybe even a normal person who's otherwise very competent may not actually do things as well as he should be doing. But then if you look at the complications of intubation in the critically ill patients, in the ICU, in the emergency department, patients crashing on the wards, if you look at the reported literature on the number of complications in critically ill patients, you'll find cardiac arrest 3%. Now if 3% of my patients have a cardiac arrest, with 20,000 anesthetics in a year, I'll be having 6,000 cardiac arrests. I'll be lose my job in that month, right? In that year. Next year I won't have a job. Esophageal intubation is almost 10%. Severe hypoxia, 26%. Okay, hypotension, 25%. So I mean, the things seem to be very different in the intensive care unit. And in the same NAP4 study, which found a very low problem in the OT, look at what happened in the ICU. Okay, so they looked at some events that occurred in the ICU. About 20% events happened in the ICU, difficult airway disasters. But 60% of those events led to brain damage or death, okay, as opposed to 14% in anesthesia. So if you had a problem in anesthesia, about 14% of your difficult airway situations would land up in a disaster of brain damage or death. But if you had a difficult airway problem in the ICU, 60% of your patients would land up with brain damage or death. And they found that these events in the ICU and emergency department are more likely to happen out of hours, managed by doctors with less experience, and led to permanent harm. And capnography was another important thing. I mean, in anesthesia, in most places or in many places, we put capnography as a matter of routine. In the ICU, it's still not happening. In fact, in hospitals where they use a capnography in the OT, they don't use capnography when they intubate in ICU, and that's a potential problem. So when you looked at all these things, we sort of asked this question, that life-threatening complications seem to occur in a significant making of procedures. So although intubation is the most commonly performed procedure, it's probably also one of the most hazardous procedures in the intensive care unit. And whether it's life-saving, of course it's life-saving, but it could be life-threatening as well. And there are many reasons, we can see. So we'll go through some of those things and how to make intubation safer. So in the OT, it's done by us. We are very good, patients are stable, they are well prepared. Even if they're a little sick, they've been optimized by and large except for emergency surgery. And but look what happens in the ICU. You'll have doctors who have just maybe MBBS, maybe they are BAMS, right? They've just, they may be from medicine, they've not done any, so varying skill levels. Patients are of course very unstable, they don't have much physiological reserve, you don't have time to prepare patients, and the environment is not great, right? Can you imagine that there's no space, the beds don't move up and down, all sorts of, we all know what is like. And this is actually a lesson for us, because many times we are called to intubate patients in the ICU, right? And sometimes you are called because someone has failed to intubate in the ICU, or they think that intubation is difficult. And we must be aware of the problems that occur in critically ill patients when we go to help our colleagues in the intensive care unit, or if you are in the ICU handling critically ill patients. Okay. And this happens. So this is how we conventionally define a difficult airway, and this has been our traditional way of thinking, right? That you can't do face mask ventilation, laryngoscopy is difficult, you can't get a tube in, you can't put a supratontic airway in. So you can't do some procedure to get a tube in to restore ventilation, and that's what we define as a difficult airway. So this difficult airway problem is something we've created for ourselves, basically to make our life easier, that we paralyze the patient, isn't it? We paralyze the patient. That makes the intubation procedure so simple, and patient doesn't cough, move, nothing. The catch is that in this period of apnea, before the patient starts desaturating, we need to get a tube in. If not a tube, we need to get the face mask ventilation going, or we need to put a laryngeal mask in. We need to get ventilation going in somehow. If we are not able to do it in time, during that apneic period, and we are not able to do it in a safe period of time, patient desaturates. And that's what we call as a difficult intubation. You can't put a tube, you can't do laryngoscopy, and then you get hypoxia, hypertension, and death, right? But the real problem is, or not the real problem, an additional problem is, suppose your pre-oxygenation, which we do to extend your safe duration of apnea, if that is not adequate, suppose a patient desaturates faster than what you expect, and this happens very often. You've got pregnant patients, they desaturate much faster. An obese pregnant patient desaturates very fast. You've got a patient who's undergoing a laparotomy for perforation peritonitis, already septic, and he has a little, he'll desaturate very fast. So these patients, in spite of maybe not even having a very difficult airway, technically difficult airway, because of the physiological or the pathophysiology that is there in this patient at that point in time, they have a physiologically difficult airway, they desaturate very rapidly, and that makes your intubation hazardous. Okay, not difficult, but hazardous, because these patients, you don't have a margin of error. You put the tube in the esophagus once in this patient, that patient's saturation will go down to 60% before you get your tube back into the trachea. Okay, why does this happen? Okay, so we traditionally pre-oxygenate our patients, and pre-oxygenation means we replace the functional residual capacity in our lung. The nitrogen is replaced with oxygen. We give lots of oxygen. So this is what traditionally happens, right? So this is your lung volume, which is normally say 2.5 liters is your FRC. Okay, you give 100% oxygen for some period of time, and you get 90% of your FRC is replaced with oxygen. And if you have end-tidal oxygen monitoring on a gas monitor, we say the pre-oxygenation is complete if your end-tidal oxygen reaches 90%. So if you reach 90% of your nitrogen is replaced with oxygen. So this is what happens in a normal lung. But in someone who's got acute lung injury for whatever reason, the FRC itself is very low. So even if you've replaced 90% of the FRC with oxygen, the amount of oxygen in the lung is very small, is much, much less than what you had in a normal person. And that is why this person has a very little low oxygen reserve and is going to desaturate much more rapidly. Okay. On top of it, there are some patients who have additional complications in critically ill patients, or someone who's undergoing emergency surgery, right? They may have a low cardiac output for whatever reason. They may have myocardial ischemia, they may have anemia because of blood loss. They've got lung disease and a low FRC. So that oxygen, amount of oxygen is low, or oxygen delivery is low, but the consumption is also very high. Maybe they are febrile, maybe they have perforation peritonitis, they've got sepsis, they're tachypnic. So they have low oxygen supply and a fast, rapid oxygen consumption, and so they will desaturate much faster. Okay. And so when they did the study, they looked at patients who were pre-oxygenated, but the sick patients who were being intubated in the ICU, the PO2 increased from 64 to only 86. They didn't even touch 100. Only 15% of patients reached a PO2 of 100 with pre-oxygenation when they were critically ill, as opposed to if you're a routine patient undergoing cardiac surgery, your PO2 increased to 400. So if you are sick, then pre-oxygenation is not really effective in increasing the oxygen levels, and your FRC is also reduced because there is lung disease or lung damage or whatever it may be. So you're in a very precarious situation. So can you imagine what happens to the poor patient in the ICU at 3 a.m. in the morning? He's the sickest patient in the hospital, and he's being intubated by the junior-most person in the hospital, the junior-most resident in the hospital, because no consultant is going to be there at 3 in the morning. Right? In a very stressful situation, he has a difficult intubation, or he has difficulty in intubation, puts a tube in the esophagus, makes 2-3 attempts, little bit of bleeding, okay. Somehow manages to get the tube in, but in the meanwhile, this patient has suffered hypoxia and maybe bradycardia and cardiac arrest. And that is unfortunately what happens in many of our ICUs at some point in time. So we could argue that, all this magajwari, why don't we just not give a relaxant? Like we say, right, when we have a difficult airway in the OT, the safest option is an awake intubation, or just a little inhalation induction, keep the breathing spontaneously going in. And there was this one study which was actually done comparing rapid sequence intubation with a muscle relaxant versus no muscle relaxant. And what they found is that, in patients who were not given a relaxant, in fact, had more complications. And probably because the hypoxic, gasping patients struggling, maybe the intubation became more difficult. And so if you give them sedation, the usual fentanyl midazolam or fortwin midazolam cocktails, it can actually have unpredictable effects in sick patients. So they found actually the incidence of complications was even higher. So they said if you are reasonably okay at intubation, rapid sequence intubation is preferable to going ahead with the awake, sort of semi-awake or whatever kind of intubation. So the question now is, how do we make intubation safer for our patients when we are doing rapid sequence intubation in the ICU for all these sick patients? there are many guidelines, and I'm really proud to say that the All India Difficult Airway Association came out with these guidelines for intensive care, intubation in the ICU in 2016, and these are the first guidelines anywhere in the world. Okay. Unfortunately, people don't cite our guidelines as much as the British guidelines, which came out later, but ours were the first, and they still sort of stand. They were published also in the Indian Journal of Critical Care Medicine, but first in the IJ in 2016. And it sort of gives a whole sequence of events. I won't go through them in great detail, but it's sort of stepwise what to do and what to do if something fails and what to do next. There are other guidelines. There was a French guidelines, and in 2018, the Difficult Airway Society also had these guidelines. Okay. The sum and substance of all these guidelines, and especially ours, is that if you want to make your intubation safer, there are two basic approaches. One is to improve oxygenation during intubation, and not just pre-oxygenation, but during oxygenation, which we call as peri-intubation or per-oxygenation, whatever you want to call it. So one is you improve pre-oxygenation. How do you improve pre-oxygenation? Instead of your standard mask and bag, there are two options. One is high-flow nasal oxygen cannula, and I think after COVID, everyone knows high-flow oxygen because that's second nature. And the other is non-invasive ventilation. Right? So you have in the ICU, you will have the ventilator. Even if he's not ventilated yet, you put him on non-invasive ventilation with a mask and keep a PEEP of 5 to 10 and pressure support and 100% oxygen. So that's extra PEEP that you give expands the FRC and increases the oxygen reserve a little more than you would without that. So that has been shown in trials to actually significantly make intubation safer. So that is, you improve your pre-oxygenation. During your period of apnea, while your patient is apneic and you're doing a laryngoscopy and trying to get a tube in, you should give apneic oxygenation. Now, apneic oxygenation you can give by two ways. One is a standard nasal cannula at 15 liters per minute, and the other way is to continue high flow nasal oxygen at 60 liters per minute and 100% oxygen. So during the period of apnea, if you give this, it can extend your apnea time and make it even longer and therefore safer. The catch in this is that if your lungs are bad, then apneic oxygen is not likely to be highly effective. So if your lung is moderately bad, high flow nasal oxygen may be effective. If it's not bad, it is going to be less effective, but definitely more effective than no apneic oxygenation. So I think we should give apneic oxygenation while you're doing the intubation after paralyzing the patient. That is one approach. And the second one is obviously to get your tube in the first time and in the shortest possible time. When we are teaching students, it doesn't matter because they put the tube, they take a few attempts to put the tube, and then after struggling, put it in the esophagus. We said, doesn't matter, we take it out. I've done it with Dr. Khon may tell you how often we have done it. But, it's not a big deal. But that can't happen in a critically ill patient. You have to get the tube in the first time, and you have to get it in a short time, right? So how to reduce intubation difficulty, right? And there are two approaches. One is to use a video laryngoscope, and the second is to use a stillet or a bougie up front. You're not at your second or third attempt, but when you're making your first intubation itself. We'll go through some of these things. So how do you decide when to use non-invasive ventilation, pre-oxygenation or high-flow nasal oxygen? The sicker the lung, the more is the indication for non-invasive ventilation. If the lung is not very sick, say intubating a Guillain-Barré or organophosphate poisoning, high-flow nasal oxygen is very good, not a problem. But if your PF ratio is 200 to 300, is mild respiratory failure, high-flow nasal should be okay, but otherwise you should use non-invasive ventilation. So use non-invasive ventilation, and during your period of laryngoscopy, you should keep the high-flow nasal oxygen, right? So that's one way of sort of doing it. Very often, people want to do a crash intubation, they don't ventilate after you give a relaxant, right? Now, even in obstetrics, we've sort of come around to, you should give probably what we call as modified crash induction. We do give positive pressure ventilated limited pressure. And even in the ICU, I think it makes a lot of sense to give positive pressure after you've given your muscle relaxant. And this was actually, it seems such a small issue, but this was a large randomized trial. It was reported in the New England Journal of Medicine. Okay, so it's a big issue for people. Okay, so they just compared two groups of patients. That one, they gave bag mask ventilation after relaxant, and the other did not give bag mask. They did a conventional crash intubation with cricoid pressure and vent head. And of course, the amount of hypoxia and number of patients getting hypoxic in the was much lower in those who got back mask ventilation, and saturation was much higher in those who got back mask ventilation as those who did not. So I think that's pretty clear now that in the ICU, that's one way of avoiding the problem, is to continue back mask ventilation and then stick on the high flow nasal oxygen during the period of apnea. Okay. Video laryngoscopy, I think in the OT there is very good data and very good evidence that it makes faster first time success rate. That sort of data is not there for ICU patients. Somehow randomized trials in the ICU have not been able to demonstrate a difference. The people who use video laryngoscopes like us do think it makes a difference, but I think it's got to do with the learning curve, and especially if you're using a curve hyperangulated blade, you need to have a stilet, shape it properly, and maybe it's got something to do with that. But definitely one of the approaches to improving your success rate is video laryngoscopy. And the third thing, like I told you, is you must use a stilet upfront rather than at your second or third attempt. And this was a very nice trial which was published. It's called a stiletto trial. In almost 1,000 patients, right? So in one group, they routinely put a stilet at the first during intubation. In the second, they did not use a stilet. They just used an ordinary tracheal tube like we did. And the first attempt success rate was significantly higher with the stilet, and the number of complications were lower with the stilet, and injuries were not different between the two. So, if you use your stilet properly, I think it's probably a way forward that you should use a stilet. Now, this is from our guidelines. So, let's say you have tried to intubate, but you've not been able to intubate, right? 1 or 2 attempts. We said at the most 2 attempts. Don't fool around too much in a sick patient. Then you should put a supraortic airway device to maintain oxygenation. When you put a it should be a second generation device, so that you can give slightly higher pressures. These lungs are stiffer, the patients are sicker, so you should give a second generation device. Now, in anesthesia, once you put a second generation supraortic airway device in, you have multiple options. One is you can continue the surgery on the anesthetic, on the laryngeal mask. Even if it's a cesarean section, you could probably finish it on a laryngeal. Or you could postpone the surgery. You don't have this option in a sick patient whom you are going to intubate because he's very sick and he needs to go on a ventilator. So you have to either intubate through a laryngeal mask, which can be quite tricky in a sick patient, because it means disconnecting, putting a tube in, then taking it out, and then if it doesn't go in, there's a problem. Go ahead and do a tracheostomy. Okay, either surgical or a percutaneous tracheostomy. Right? Again, if you can't intubate through a face mask, you're back to the same step. You rescue face mask ventilation if it's possible. Quickly do a tracheostomy. Get someone in to do a tracheostomy while you're ventilating the patient. If nothing works, then you're in a soup. We call it complete ventilation failures. The British used to call it CICO. C-I-C-O. CICO means kashala. Right? And it has different meanings for different people. Kashala, asad, sogits, zaude. So CICO is not a good term. We don't agree with the word. It doesn't give a sense of urgency. What's happening there? CICO. Does the surgeon understand what is CICO? He doesn't understand what is CICO. We have to convey a sense of urgency. That's a desperate situation. So cannot intubate, cannot ventilate is little better because it tells you what is happening. We call it complete ventilation failure because it means nothing that you're doing is able to get your ventilation going. Okay, and once you're in complete ventilation failure, you have to call for help again, because this is the time when even if you've been through simulations. Now I think one of the drawbacks of simulation is sometimes people treat it as a game. That chalo, arey tera tube nahi gaya, arey patient mar gaya tera. It happens in simulation, right? The saturation goes down to 60%. Now your patient is dead, and you get a flat line, and everyone claps and you go home. In the ICU or in the OT, if this is actually happening, patient's pulse rate is 20, saturation is 20, your pulse rate is probably 200, right? You can't function normally, so you must, or you may not think rationally, or you may not perform. Because I've seen people, the cricothyroid needle has fallen down because they just can't hold it, because their hands are trembling, right? So you need to get some additional help. So call for additional help, okay? And then you try and do a rescue cricothyrotomy or a needle cricothyrotomy. I won't go into the details of that, but that's what you need to do and convert to a tracheostomy. So that's roughly how you would sort of handle this. So if you come to this stage in an ICU patient, you're not likely to have a very good outcome, because in any case the patient was not good to start with and he gets so severely hypoxic. So the best way is to try and do all those things to get your tube in early, first time, as fast as possible. Now, we had focused a lot on oxygenation and hypoxia, but there is also another big problem in these patients, that is hemodynamic decompensation. Many patients are septic, some patients and then they may be hypovolemic, they may be trauma patients, right? So and it is not unusual, I think many of you had seen it, especially in sick patients, that you intubate the patient and soon after that, within 5 minutes, the patient's BP is crashing. And there are many reasons for that. One is they may be hypovolemic to start with. On top of that, you give an induction agent, which depresses the heart and vasodilates further. When you start IPPV, the venous return decreases, again the cardiac output falls. A patient who's sick, who's breathing rapidly, tachypneic, he's anxious, he knows he's not in good shape, he's probably going to die. He's got a big adrenergic stimulus. The moment you sedate him, that stimulus goes away and the BP starts crashing. Okay? And sometimes, you have a patient with sick lung, they already have the pulmonary vascular resistance increased because of the pathology itself, and then you put a tube in, and our tendency is the sicker the patient, the harder and faster you bag, isn't it? So that over distends the alveoli, that actually increases the pulmonary vascular resistance because the intra-alveolar capillaries get squeezed, increase the PVR, and in a sick patient that can actually provoke what we call as acute cor pulmonale or acute right heart failure, and the patient can crash. Right? So many reasons why a patient may actually have a hemodynamic collapse after you intubate the trachea. So that's another big threat to the patient in the ICU. And this was a very nice observational study which was published last year in JAMA of intubation practices and adverse events from 29 countries. It was a multinational study over multiple ICUs, including many from India. And what they found was the incidence of hypoxia was probably not very high. It was severe hypoxia, it was 9%. And maybe some of the things we talked about were being done in many of the ICUs. So maybe, but what they found that the most common and the most severe complication was cardiovascular collapse. 43% of patients had severe cardiovascular instability, which would have a BP of systolic BP of less than 65, or need for vasopressors or fluid or something like that. And 3% of patients had cardiac arrest. Okay, so cardiovascular collapse seems to, hypotension, severe hypotension seems to be a problem. And one of the things is, we don't use the cardiostable drugs. Now, the two cardiostable drugs which we have in our armamentarium are etomidate and ketamine, right? And ketamine, for some reason, is extremely underutilized. So, in fact, people in France, this French group had to do a trial to show that ketamine is safe. In fact, it's as good as and as stable as etomidate in critically ill patients. So, we should use these two. The INTUBE study, when they analyzed the results further, they found that propofol was used in 40% of patients. And propofol in a sick patient who's septic or who's hypovolemic or who's got a bad heart is a recipe for disaster. Okay, propofol is banned in our ICU for intubation, right? So we don't use propofol for intubation. And of all the factors that they analyzed in the INTUBE study where the incidence of cardiovascular collapse was very high, the only independent factor that was associated with hypotension was propofol. So I think if you are called to help someone in the ICU to intubate some patient, don't give propofol. Okay, use ketamine, use etomidate, but don't use propofol because that can cause problems. Can we give fluids prophylactically to prevent hypotension? Can we give a vasopressor prophylactically, to prevent hypotension? There was this study which was done, which was reported, where they gave a bolus of fluid, about 500 ml before intubation, and they found no difference. Okay, so to prevent hypotension. We are now doing a study, and there are many studies going on, evaluating prophylactic vasopressors. So before you start intubation, 5 minutes before, start a small dose of noradrenaline and see what happens. We'll see. It may work, it may not work, it may be counterproductive because it may cause hypertension, because we know intubation causes a little hypertension. If the NORAD is there, maybe something, we will see what happens. But we have to do something to prevent hypotension, or at least be aware of it and treat it very rapidly. So even if you can't prevent it, I would suggest that, like in the OT, every time you have, you induce and a little hypotension, you give something, isn't it? You give either mefentin or phenylephrine or ephedrine or whatever is your favorite vasopressor you give it. So maybe we should have something like that ready in the ICU, and many patients will be requiring vasopressor, so maybe a NORAD infusion prepared beforehand and ready to go as soon as this thing, or prophylactically, we are not very sure. The Intube study showed us many other things, lot of this thing, right? No protocol for intubation, 34%. Apneic oxidation, which we talked about, only 10% of our patients had this. Video laryngoscopy was used in only 17%, and it's not that we are resource poor. There were many resource-rich countries in this survey, and still only 17% usage of video laryngoscopes in the ICU. Capnography to detect tracheal intubation, only 25% were using it. I mean, there's something seriously wrong with the way in which we are dealing with patients in the intensive care, even in 2020-21. Okay, in spite of all the knowledge that we have and all the data that was given to us by LAB4 and all our guidelines and everything, there is some problem. So there is definitely scope for improvement in the way we practice in the intensive care unit. Of course, training, skill acquisition, simulation, dissemination of guidelines, but implementation of the guidelines. There's no point rattawing guidelines in your exam, but you should be able to use them at the right time in the ICU. And of course, we have to focus on communication, technical skills, and so on. So there's a lot of room for improvement. We've made intubation very safe in the OT, and we need to do better in the intensive care unit. Yeah. Thank you very much for this.
I think you left no doubts to say that the management of the airway in the ICU is life-threatening. With all the suggestions that you have made, I don't think the matters will change much for improvement. Main thing must be oxygenation, and then the management of the BP falling and things like that. What I feel is if all these intensivists were to be replaced by trained anesthetists, do you think it will make a difference?
It will make some difference because your skill levels are there, but I think the innate, the problem lies also with the patient, and it also lies with the system.
See, everything is against the patient. So the skill required is much more than what is prevalent in the ICU. You will be surprised that I have been called to the ICU not to put a tube, but we can't remove the tube. So that only reflects the skill level, nothing else. The relative of the patient who was a doctor, he said, don't touch my patient, call Dr. Bhatia and he'll remove the tube. So I think there is no question of life saving, or it is life threatening. There is no doubt about it. And that is what prevails in our country.
Yeah, I think training will make a difference, but the situation which she's been emphasizing throughout the lecture was how difficult and different the scenario is. I have been suddenly called from OT, there is a problem in London, and often the culprit is broken. The intubation study did show that a very compromised patient, little propofol, and we have seen I have seen at least 2 or 3 arrests which could not be resuscitated. And in that case, I concluded propofol was the only culprit. Had it not been used, this patient would not have died. I mean, now since he's already said he's not even recommending it and taken out. So I think even anesthesiologists who are not core intensive care, when you're called to ICUs or in critical areas for intubation, keep in mind that patient is quite different from what OT patient and this patient is. They are very, very compromised, they are on vasopressors, they have multiple morbidities. So any depressants like propofol will obviously cause a crash. We have 1 minute for 1 or 2 questions.
Do you recommend video laryngoscope for first attempt intubation or the conventional?
I would, provided you are reasonably well versed at video laryngoscopy. I mean, for a very first use of video laryngoscopy, don't use it in the ICU, but if you've used video laryngoscopes and are reasonably well versed with the use in the OT, I think it makes a difference in that.
What about benzodiazepine, midazolam use? Midazolam use?
Midazolam, I think, is not as safe as we think, especially in sick patients. Okay? So,
again, the hypotension is a problem. Don't underestimate the ability of midazolam to crash the cardiovascular system.
I think I have a lot more respect for midazolam after working in the ICU than in the OT.
So do you think any more formal training for all the personnel working in ICU?
Of course.
In mask ventilation, face mask ventilation, maybe on simulators or other patients, I think that will make a lot of difference. and that will also encourage use of relaxants. You clearly showed that the use of relaxants was also made a lot of difference.
I agree, madam, and I think not just in ICU, even in OT. It's today's culture in the West and in India nowadays. When you use laryngeal mask, people lose two skills. One is intubation skill and one is bag mask ventilation skill.
Absolutely,
So we have 1 day a week, 1 week in a month in Tata. It's called a no laryngeal mask week.
Great.
How long? One more suggestion. Even in the operation theatres, when there is going to be likely to be a difficult intubation, they say video laryngoscope here. My suggestion is that unless you routinely use the video laryngoscope, just keeping it ready when there is going to be difficult intubation is not going to improve matters much. So as a routine, passing an endotracheal tube with the bougie already in a routine case and keep trying to sort of do every other intubation with a video laryngoscope is also only going to improve the skill of the anesthetist also.
Absolutely, completely agree.
So one more thing what I have now done is rather than bag mask ventilation, the patient who is compromised because of pulmonary, either pulmonary edema or ARDS or COPD with bronchopneumonia, give sedation. Relaxant of course is often given, and put an NIPPV or NIV on that, so that that PPP effect probably improves the reserve or oxygen reserve to some extent, which will not happen with the bag mask. So that is one modification I have been suggesting continuously.
I take your point, it's a good point, but the skill there is to maintain the airway.
I know, that obviously.
And hold the mask tight so that there is no leak.
One thing is that during our training in residency and throughout the career before the invention of LMS, we were taught to ventilate, bag mask ventilate, and we were made it compulsory to ventilate, bag mask ventilate such as small cases. So up to 30 minutes we used to bag mask ventilate. Now with LMA, how long can we put on patient on LMA and ventilator in ICU?
No, that's the problem. You can't put for a long time because your pharynx will just slough off because of the pressure. So in fact, when I was training, Dr. Khon was kind, but some of my senior residents, they would make me do a whole case on just holding the mask. Right? So we are pretty good at holding a face mask and maintaining the airway. That skill is a vanishing skill.
Thank you so much. I think it was a very informative lecture. And
Sir, one last.
Besides overview,
Please. I just wanted to add. I think how many of us, I don't know, practice bougie. We practice bougie only probably when there is a difficult intubation or otherwise. My submission is that all of us, including us and the trainees, should be allowed to use a bougie in a normal patient with a good view and to get that feeling of gritty sensation of the trachea. So in case of emergency where you cannot visualize anything, you'll be better off in
routinely use a bougie.
Yeah, and get that experience of tracheal sensation.
Yes, sir.
And not only that, if you have the finances with you, routinely use a video laryngoscope.
Video laryngoscope, I think most of the ICUs are now procured on that. No blind nasal intubation ICU. 1/3 of the patients have coagulopathies. No such occurrence. Thank you. So thank you very much, Jiggy, and we'll close the session here. Thanks.
Thank you, sir. I now request our chairpersons to kindly felicitate Dr. Jiggy Devadaya, sir. I request Dr. Thomre and Dr. Khon to kindly come on stage to felicitate our chairperson. Thank you all so much.
We move on to our next session. Anesthesiologists have been performing diverse interventional procedures using anatomical landmarks over so many years, with variable success rates, risks, and complications. Fortunately, the technology of ultrasound in medicine has evolved leaps and bounds over the years. I request Dr. Nupur Chaudhary to kindly come up on stage and carry on with the next session on USG in anesthesia.
Good morning to all. USG is the most exciting technological advancement in the field of anesthesiology. So without wasting a minute, I think I would like to extend my warm welcome to chairperson of this session, Dr. Satish Phadke sir and Dr. Abhinay Harankhedke sir. Please come on the stage, sir. And Dr. Satish Phadke sir is the consultant at Cloud9 Hospital and has special interest in regional anesthesia. He is the faculty in many regional anesthesia workshop as well as conference like Aora, Misakon and Takon. Dr. Abhinay Harankhedke sir is very well known professor and head of the department anesthesiology at Ullas Patil Medical College, Jalgaon, and he is also consultant at various private hospitals at Jalgaon. Now I would like to hand over the session to you, sir.
Hello. Let us welcome the speakers. I welcome Dr. Sandeep Diwan for interfacial plain blocks. Sandeep Diwan is a well-known person in regional anesthesia since many years, and he needs no introduction. He is very much interested in research and especially injecting dye and so much exploration. Recently, we will be waiting for the new edition of his book, and I have the first edition and I am just waiting to see what is new in the new book. Welcome, Sandeep.
Interfacial.
Yeah. Thank you very much, Dr. Satish, and thank you, PROACT, for allowing me to present my work here, sort of. So this is about interfacial plain blocks, and as Satish has mentioned, I do a lot of cadaveric as well as contrast studies. Now, it's not moving. Slides not. So next slide, please. Can you move to the next slide? Next slide. So this would be my presentation. Next, please. So block has been characterized by its simplicity, effectiveness, reproducibility, though they have certain limitations as well as some complications which are always associated with. Even the interfacial plain blocks are known for it. So I'm going to discuss these blocks, the transverse abdominis, the chordatus lumborum and erector spinae, for example. Now, this is one of the cadaveric slides that I want you to focus on. Now, they all are in the same plane. For example, now, the erector spinae, which is just behind the transverse process, the chordatus lumborum plane, which is lateral to the transverse process, and the tap, again, which would be lateral to the chordatus lumborum. Say, if you inject a very huge volume of local here, maybe around 100 ml, we have injected not the local, but we have injected latex or maybe methylene blue dye. It has traveled right up till here at this point, and it would travel right into the neuraxial space. So potentially they seem to be all interconnected with each other. It depends upon how much volume you would be injected in each of these planes, and that would determine the outcome of the blocks, the clinical outcomes which we define as the pain the patient perceives, the number of opiates in the post-operative period, and the adverse events. Now, what was done in the past was they injected local anesthetic here at the region between the iliac crest, the external oblique and latissimus dorsi, and what they thought was that it would carry the local anesthetic right cephalad and block all of the intercostal nerves. That was what was thought of Petit. It was a very honorable thought because one single placement of the needle would block all the nerves. So this has come to with ultrasound guided block now, where we place the needle mid-axillary line from cephalad to caudal, and we try to inject posterior to the mid-axillary line, so that where there is a good placement of these nerves in the tap plane between the internal oblique and the transverse abdominis. So we find that you keep on clicking. We find that the lateral and the posterior are the ones which we try to inject the local anesthetic in. And what the previous slide, please. What the cadaveric studies found was that the dye was exactly in the tap plane, as well as it was in the paravertebral area. So this was something very different. The tap going to the paravertebral and the tap in the tap plane itself. So this is what they came into conclusion. But what was found was that with the limitation was nothing below above the umbilicus, everything below the umbilicus. It means the tap was meant only below the umbilicus and not above the umbilicus. So this was a major limitation. So what they came up with was the upper subcostal in these areas, just below the diaphragm. They try to inject local anesthetic with the in-plane technique, with the needle coming from the medial to lateral. And what they thought was it would block all the nerves coming from T6 to T10. But the major limitation was, again, it was just the T9 which was involved. So do you want to give the tap block, the upper tap, just for one nerve? That was the question again. So what they did was they combined both the dual block, which was the subcostal, with the lateral, and they placed the probes at all these areas and injecting local anesthetic in all these areas. And they said that the part of the abdomen could be blocked. So what they did was they did some studies, and they found that the contrast going in the erectospinal plane, the contrast going into the tap plane, the contrast going into the caudal lumborum plane, huge volume of local anesthetic, more than 0.6 ml per kg. Would you be using in clinical practice? Comparing what we are doing with epidural, segmental epidural, or thoracic epidural, where you would be using just 7 to 8 ml, against a 40 ml or maybe around 80 ml of local anesthetic for all these cases. Next, please. Going beyond that, one case report in recent IJA published 4 catheters in 4 quadrants and 4 infusion pumps at a rate of 0.1% ropivacaine, 8 ml per hour. So you have 34 ml per hour or maybe 36 ml per hour going at one single point of time. Would you be doing this in all your cases? And compare it with just a single placement of catheter in the epidural space. Apart from that, ultrasound does produce complications. It's very safe. It all depends upon how you see the needle, how you visualize the needle tip, how you place the drug into the space. There have been reports of splenic perforation, hepatic perforation, and there have been cases even of intraperitoneal injections. So 8 studies, more than 350 patients, limited evidence. What you need to do is you have to compare a tap with intravenous morphine and tap with epidural. This would help us more into coming to a proper conclusion. I was very fortunate to have Rafael with me. He's a very good friend of mine. We have a lot of discussions. He was in Sanjiti Hospital. He had proposed the QL2 and QL1, and we had a lot of arguments, plenty of arguments. And QL3 was produced by James Boglan. Now, posterior to the quadratus, lateral to the quadratus, there are no nerves at all. What made him give this block? In front of the quadratus, you have at least one nerve, ilioinguinal nerve and subcostal nerve, 2 nerves maybe. So why the anterior quadratus lumborum is chosen just for one single nerve? Is there anything else apart from that? There is, because Rafael mentions that there is sympathetic innervation, which helps in decreasing the visceral, providing the visceral analgesia in these studies. These are all the posterior, lateral, and the anterior, you know. Just click on it. So this is the anterior quadratus, and I have given a lot of this. I have used this in acetabular surgeries. We have placed catheters, and we have used this as a continuous infusion in the post-operative period, and it does act well. In a sense that, next please, they have these authors from various countries, and they studied the dye injection into the quadratus lumborum, and they said that it goes right up to the thoracic paravertebral space, to the thoracic sympathetic trunk, with the ventral raphe, subcostal, ilioapogastric, ilioinguinal nerves. Do they block all these nerves? Next, please. This is a study that we published in IJ, and I thank Dr. Devatia for accepting this. This had gone all around the world, and it got published in IJ. What we did was, we identified at certain levels, upper pole, mid pole, and the lower pole of the kidneys. We inserted at each of these points, inserted catheters and injected contrast. We found that if you inject at the upper pole, it goes into the thoracic paravertebral. In the lower pole, it goes more caudal. This is the way that you might be doing your caudal lumborum block, specific for specific type of surgeries. In Aurangabad, in Hedgewar Hospital, along with Dr. Mehta, I conducted few studies where after inserting the catheters, we opened up and we found that due to the resistance, the catheter had coiled, and sometimes due to force, the anterior thoracolumbar fascia had breached. So you need to push in your catheters very carefully. So this is another where we use the supine chordatus lumborum block in patients with acetabulum. We did not position them lateral. This is a supine position. We published in Brazilian journal. And we found the contrast going right into the anterior thoracolumbar fascia, right from the lower pole of the kidney. And if you increase the volume of the local anesthetic, it still moves more separate and more caudal, thus blocking all the nerves. It's really good for the acetabular surgeries. Hypotension, hematoma, lower limb weakness has been reported because the drug can breach the anterior thoracolumbar fascia and go into the lumbar plexus. This is the lumbar plexus. That's the spinal cord and the erectile space. It can move there, and we have seen this. Next, please. We reported one catheter going right into the paravertebral space, and when we injected contrast, bilateral lower limb weakness. And we found that the catheter in the paravertebral space, the drug going right up to the thoracic. Post-operatively, we could not distinguish what was the problem. So when we did a contrast study, we found that the thoracolumbar, the chordatus lumborum going into the paravertebral, into the epidural, right up to the thoracic area. The evidence, cesarean section, QL better than opioids, equal to morphine. In non-obstetric abdominal, QL better than TAP, of course. And QL is better than TAP for hip, and QL is equivalent to ESP and the fascia leca block. This is again an area of concern. The QL is a separate plane, ESP is a separate plane, fascia leca block is a separate plane, having different kind of nerves. So why would they would be addressing the hip with equal block efficacy? I'm not sure. ESP, this is the spinous process. That's the costotransverse junction. This is the erector spinae. That's the plane, paravertebral space, and the erection space. This is the way you keep the needle or position the needle tip just below the erector in the erector spinal plane. And this is where you inject your local anesthetic and insert your catheters. Just keep on clicking. That's the local anesthetic plane. Click, and that's the catheter going into the erector spinal plane. So 30 ml of 0.1% ropivacaine, and this is 0.1 ropivacaine around 5 to 8 ml per hour, depending upon what areas are to be blocked. Patient in sitting position, if you insert the catheter, by evening you'll find that the dermatomes have extended above the nipple and up to the hip joint. This is because of respiration. We are conducting now another study where we are inserting the catheters, inserting dye, and we are doing a functional MRI. And we're trying to see how it keeps on spreading at certain hours. So that you can use it in several areas like fracture of the ribs, fracture of the transverse process, and of the sacroiliac joint. Single catheter placement, it moves caudal and cephalad. This is the contrast which goes right into the epidural space. This is one of the mechanisms that has been proposed in volunteers. This is what we published. Just keep on clicking. This is when you insert in paravertebral and it goes into the epidural space. And this is when you inject in the erector spinae, goes into the paravertebral and epidural. When you inject in the paravertebral, goes into the epidural and goes into the erector spine. But that is formalin based. It will be different when you do it in thiel embalm, and still different if you do it in fresh frozen cadavers. This is a clinical study where you see that the contrast going from the ESP, paravertebral, intervertebral foramen, posterior space, and contralateral epidural space. In thoracic spine, when you do the ESP on one side, wait for a few minutes, see for the hemodynamics, then go for the other side. is likely to cause a fall in the pressures. Other areas which are recommended, cervical ESP, just click. This is a patient who we had given the cervical ESP bilateral for posterior thoracic spine, and you can see the patient awake and responding to command. The catheter, this is a phrenic sparing block that we published, 20 ml of 0.5% for shoulder surgeries. There are a lot of controversies and arguments still going on this block. So until it gets established and substantiated with a lot of evidence, you keep on doing these studies. Lumbar ESP, yes, just behind the transverse process, there is a possibility of the drug going into the epidural space, and the paravertebral and the epidural space. You can see that this is the nerve root and the contrast right close to it, and this is again the nerve roots and the contrast right by the side of it. So single shot is not going to go into the paravertebral, but a constant build-up of pressure because of the local anesthetic might lead the drug into the paravertebral. So ESP in hip fractures, surgeries of the thoracic, breast, cardiac, abdominal and lower limb. I am still skeptical about its use in the anterior segment surgeries because it's a dorsal rami block. How does it act ventrally? There is some missing link which I am not going to commit. You can read it and you can let me know about that also. For example, you choose hip. Block type is fascial like a block. Nerves are femoral LFCN. Quadratus lumborum block, these are the nerves. Lumbar erector spinae block, these are the nerves. Different nerves, different planes for the same procedure. Is it applicable? What's the evidence? So you need to read about this and you need to inform me also so that I can upgrade myself. So what can be done? No more studies, block versus placebo or block versus recommended. No more studies. It's done, it's established. But block versus block. QLB versus fascial ESP versus QLB, something of that sort. Studies should have endpoints, clinical outcomes, the group should be homogeneous, results should be homogeneous. Then they can pool, analyze, and then we can be informed or you can inform somebody else. This is just to invite you for AORA 2023, which is in Pune. And there will be consultants who will be from corporates, non-corporates, freelancers, post-graduates. We welcome you all. And Satish, this is the book which will be released in AORA. Thank you very much.
Hello. Thank you very much, Sandeep. It was very enlightening. And actually, I wanted to ask few questions, but in the latter part of his presentation, he completed those sections. We will not be surprised that in future, in regional anesthesia books, there will be a chapter on different facial planes and its relation to other facial planes, its limitation of injected fluid which can spread to other facial planes, and the nerves involved. And for future students or register, these will be good topics for dissertation or some such things. Hope so.
I request our chairpersons to kindly felicitate Dr. Sandeep Diwan sir.
So next speaker is Dr. Amit Dixit, who needs no introduction also. Very well-known figure in the regional block. Dr. Amit Dixit is a consultant anesthetist, Ruby Hall Clinic. His topic, perioperative UAG.
Amit is very passionate about USG, especially POCUS. I have heard him several times and is always eager to do more and more studies related to these topics. Welcome, Amit.
Thank you. Can I have my slides, please? Thank you very much. Yeah, at the outset, I would like to thank the organizers for giving me this opportunity. And I am finding now a POCUS is integral part of each and every anesthesia conference and workstation and everywhere. Thank you, chairpersons, for those kind words. Slide, please. I think, yeah, thank you. So, greetings to you all from Ruby Hall Clinic. 2 days back only we had this basic fit workshop as a part of PROACT PuneCon, and it was a houseful show. And the workshop was sold out immediately within 10 days, and there were 30 delegates. We completed basic fit, and that was the beginning of this PROACT PuneCon on Friday. So coming to my topic, the point of care ultrasound and usage of ultrasound. Previously we were talking about inspection. Yeah, there is a loose connection, I think. Inspection, palpation, percussion, and now insonation is the fifth pillar, and we have to think about ultrasound. Now the world is more or less divided with the help of ultrasound, those who have access to ultrasound and those who do not have access to ultrasound, because the precision, accuracy and the way we think and way we react to the situation is changing drastically. So if I may ask, how many of you have access to ultrasound? Great, great. So now I can speak something more with ultrasound and skip few of the slides. That's very nice. So now we have a structured curriculum. We have this upcoming AORA focus point of care ultrasound workshop, and this has been followed even in ASRA workshops as well. So we have a pre-course learning material, and it is not like direct walk-in for a workshop. So you have to prepare, and these are very user-friendly. And we found that it is working very well. So nowadays all these workshops, so you can also have access from the website, and they are available, and they are also available with Dr. Desurkar sir and his team. So what is ultrasound training? We have already, as everyone is, it is basically pattern recognition. What is this all about? This is probably cycle racing, because you can see a cyclist here. This is how we train, how to see RA, how to see RV, how to see lung. So it is all pattern recognition. Now what is POCUS? Am I here to replace cardiologist, radiologist, pulmonologist? No. I just want to answer some question. And the more the specific you have a question, more specific you will have answer. Say question can be, why my patient is desaturating? Is this patient high risk for pulmonary embolism? Is there any DVT? Should I give fluids or should I not give fluids? Why there is tachycardia? So I have a very specific question. It is time sensitive. Is there any pneumothorax? I cannot, am I dealing with cardiac tamponade? So something like very time sensitive, where we cannot wait for cardiologist. It is limited evaluation. I'm not doing a echo whole study. It is just a small. It is refining my differential, and it is guiding me with treatment. So where is the evidence? There is good evidence in all standard. When I talk about regional anesthesia, there is good evidence. Upcoming articles in RAPM in 2017. There are good articles on lung ultrasound, which anesthetists. So we are talking about community which covers most of the anesthetists as non-cardiac anesthetists, or into intensive care in that area. I'm sorry, this is a little loose connection here, I guess. Yeah. So this is about lung, then gastric. And what is the methodology? It is IM. So you have a specific question. There is image acquisition, there is interpretation, and medical decision making. So this has been applied to each and every aspect of point of care ultrasound. Sorry. So we have ASRA guidelines for this. I'll hold it. I think there is a little. So now if you are thinking of point of care ultrasound is optional to me, probably it is not, because now it has come into ASRA guidelines, and 2021 article is showing it. What should be done? Okay. Sorry for this. I thought I'll have more of videos, so I insisted on having it, but I think should be disconnected. Okay, thank you. Thank you very much. इधर नहीं है. Okay, so I could see slides here. I'm sorry, this is the way it is, but we'll continue with that, I think. So there are ASRA guidelines to suggest that it is integral part, and there is good evidence to suggest how much one should do screening. So there is roughly around 30 screenings for the airway ultrasound, for lung ultrasound, and it is around 50 for cardiac ultrasound. So basic FATE is basic echocardiography. So there is a basic FATE course available, and you might as well do it. Now here we should be able to detect at least the life-saving conditions like pulmonary embolism, severe hypovolemia, or cardiac tamponade, pleural effusion and pericardial. So even that position 4 is also been included. So it is a sort of a complete cardiovascular assessment. And so this is position 1, which tells us about the subcostal 4-chamber view. And even with eyeballing of this view, I can say that RA, RV, LA, LV are contracting nicely. There is no pericardial effusion or tamponade physiology. And the size of RA, RV is telling me that there is no pulmonary embolism. The valve morphology on eyeballing looks normal. So this gives me confidence. I can give spinal, I can give general anesthesia to this patient. I can look at IVC. Today morning Dr. Jiggy sir was highlighting that these are hemodynamically unstable patients. So I think it's a very good idea, before subjecting to spinal or intubation, why not just do a quick IVC scan, and whether the pre-optimization has been achieved or not can be very well seen. So this is
Make it full screen.
नहीं याच्यावरती येत नाही.
Okay.
It is stuck, I think.